the home of trauma. Every time I interact with you guys, I go home having learned so much. So for me, it's a great opportunity to come and change what I do. I'd like to second what Andy said, that this meeting is very unique. It's not about classifications, it's not about research and presentations. It's all about learning from cases we've seen and dealt with. They don't have to be crazy. There can be the straightforward cases we all see that go horribly, horribly wrong. And the idea is to share our experiences, share our mistakes, yeah, and we'll all learn from them together, okay? It's better learning from someone else's mistake, right? We've all done that. I'm just going to reverse this slightly because I'm kind of conscious with these meetings that the thank yous come right at the end, but I'd like to put this one at the front. So what I want to do is get you all to say a massive thank you to Smith+Nephew, particularly Andy and Raki, the amount of work that goes into producing this meeting. This has been about a year of hard work by these guys. This meeting is entirely for our benefit. There's no kind of commercial kickback for these guys. They provide this as an opportunity for us to come together and learn from each other. So it's really unique and quite special. So we'll actually start the meeting with a massive round of applause for Smith+Nephew, Raki, Andy, and the whole team. Perfect, we got that out of the way, that's good. So there's no hiding, you will be asked to talk. It's a really interactive meeting. If that's not for you, the door's that way. Don't be shy, there is no right or wrong answer to these cases. We've all got different approaches, we've all got different strategies. No one's as better than the others. Yeah, it's really just an exploration of concepts and exchange of ideas. We've got a great faculty. They will be like me, wandering around the room, asking for you to get involved. Please don't be shy. If people are being shy, my friend Bocky here will come and hunt you down. If we're getting a bit slow and people aren't talking, Bocky will be thrown around the room. If it comes to you, you have to catch it, you get the next question. If you duck it, you get the next 2 questions. So hopefully Bocky can sit quietly, but just beware of his coming out, you could be in trouble. Anyway, we'll get on with the interest bit. So Jitesh, I think you're first up with distal femur. So plug in and enjoy. Thank you.
Okay, good afternoon, everybody, and again, I'd just also like to extend my thanks to Smith+Nephew for inviting us for this meeting. So let's kick it off. We're going to start off with distal femur fractures, quite a common injury seen, especially in state hospitals around the country, our country with high rates of car accidents and trauma, so we do see this quite often. Now, I just wanted to start off by saying this figure, when I went through this topic, was quite shocking to me as well, and that the non-union rate in distal femur fractures can be as high as up to 22%. Of course, in the literature, it ranges from 10 to 22. It depends on the mechanism of injury, but remember, these are not easy fractures to treat. Now, this was also an interesting statistic that I picked up, and that we often see distal femur fractures in elderly patients, but we don't treat it with the same respect as hip fractures. And this study compared the mortality rates, the 1-year mortality rate between hip fractures and distal femur fractures, and found that they were very similar. 30-day was 2%, 6 months was 13%, and 1 year was 23%. So in the elderly patient, don't take these fractures for granted. Now, of course, they have a bimodal distribution, and in our setting, we see a lot of bad MVAs, young patients, high energy injuries, and then, of course, the elderly geriatric patients that have low energy fall. And often these are periprosthetic fractures that we need to manage. So let's kick it off with the first case. It's a 65-year-old female, sustained a low energy fall, comorbid hypertension, diabetes, retroviral disease with a high viral load and poor compliance on treatment. So these are the x-rays. So are there any takers? Does anyone want to start? Can describe. Let's look at table, maybe table 7. Let's look at somebody from table 7.
Anybody? Okay. So it's an elderly lady with a quite an osteopenic bone. It's a distal that it doesn't look like it's interarticular, although I can't see very well on the AP. So this is a case that I would probably, in terms of fixation, I would probably opt for a retrograde nail. That would be my take.
Okay, that is an option, and I think if you just want to be more descriptive, well, there's comminution around this area. It's metadiaphyseal, so it's actually extending quite high up. And I would say the majority of this injury is in this region, but if you look closely, what's happening down there?
There's an intraarticular extension there.
Okay, so there is intra-articular extension.
I think a CT scan will probably be
Right, of course. I don't have one. That's why I'm saying we don't have it available. But yeah, so the X-rays show this, fairly comminuted metadiaphyseal fracture, intra-articular extension. It's osteoporotic bone. I gave you a bit of the history. It's not a great host. Now, most of the cases that I'm presenting today aren't going to be perfect fixation and patients that heal, because then the point of the meeting would be lost. And so we're looking at general complications that we see, why does it happen, bad fixation, etc. But let's see what you think. All right, so this was done in theater. All right, so this was done in theater. They opted for a lateral locking plate. What do you think?
Yeah, the reduction there is not optimal. First of all,
You're very kind. It's not optimal. We're all sitting there with a different word, right?
Yeah.
yeah, and yeah, I think that's the main thing. Maybe the choice of fixation, it wasn't bad, but I would have also maybe added another plate on the middle side to buttress if.
Okay, that's an option.
Yeah.
Yeah, so there's a lot of things wrong with this. What do you feel about, let me go back. So look at the joint line. I mean, these aren't the best images, but look at the joint line and look at the plate. So what do you think about this articular block or this fragment? What has happened? So it's fixed in what position?
Sorry?
What position is it fixed in? I mean, okay, your fibula is on this side.
It's in valgus.
Right, valgus, quite a lot of valgus. And what else? So remember we said that that fragment was intra-articular. Well, you can't see clearly here, but it extends upwards into that piece. Do you think it's adequate fixation of this piece?
It's not
not,
adequate,
okay.
Yeah, not at all.
All right, and then on this view, you can see the screws aren't, they don't appear to be very long, but I'll show you why they are actually long. And again, a lateral locking plate is pre-contoured to fit the anatomy of the femur. Do you think that's correct there? Okay, it's sitting off the bone, okay? So that's your first impression that this is not reduced well, okay? It's really bad. Okay, that's the lateral view.
To the AP view.
Jitesh, can you go back one, please?
Sure.
Yes, I agree. It's an open internal fixation. There's no reduction at all. The teaching is that you first reconstruct the joint. Then I would have done that first and possibly put 2 screws, cannulated screws, to reduce the joint and then reduce it to the shaft. Then I would have opted for another plate, whether it's a 4-hole plate with 2 short screws on.
Tells a story. It's not projecting too clearly, but what can you see there now? Okay.
Hi. I think that medial condyle is not well reduced. Could possibly be a Hoffer as well that's been missed on the medial side.
Yeah, so not well reduced is also putting it lightly, right? It's not reduced at all. It's not even fixed. It's basically a free, if you follow it closely, that's the spike, and it's actually a free piece that's sitting there on the medial side, and all your screws are centered here. It's actually not fixed at all. And you've got, potentially a Hoffer. You would have needed a CT scan to see clearly. Anybody can take a guess what's the incidence of Hoffer fractures in distal femur fractures? Does anyone know? How high is it? 10%? Anyone? Okay, so it's as high as 30%, okay? So Hoffer fractures, again, we would need a CT scan to identify, and well, of course, that would have needed separate fixation. But here, okay, so we've got this fixation. What do you think is going to happen? Does anyone know? The same speaker who's got the mic, you can give us your opinion.
Well, we obviously don't have mechanical alignment is off, and we don't have that medial condyle is also not fixed. So it's just going to collapse on the medial side.
Jitesh, can you go back onto the AP, please? So what do you think in terms of the construct, type of screws, screw density? Are you a big fan of all locked constructs in fragility?
Fragility, I would definitely do lock-in distal. Obviously, you get reduction, but do lock-in distal, and in proximal, you can do non-lock-in.
Yeah. So I think there's a bit of a misconception. So particularly in Europe, especially the Germans, they tend to go all locked constructs. And I think completely agree with you. I just think it's just too rigid when you're trying to get callus formation and get it healed before the implant fails in the elderly, and they've got to walk straight away. So I completely agree that I think an all locked construct is it's doomed to fail, this one. And then I think your comment about having some sort of buttress on the medial side, I think this is kind of like what I call a reverse oblique. So the high medial exit of the fracture line, you've got to get something up there. And whether it's intramedullary with a nail, or if you're going to plate this, you've got to have something on that medial side. I agree.
Yes. Question there.
I think the other problem on the AP is the usage of screws. You can see that the plate has been locked away from the bone, from the wet go. Hence, we have it away from the bone. And hence, they use the cortical screws to try and push the plate against the bone, and it don't work because the plate has been locked away from the bone.
Yeah, I think if you look at it's in so much of valgus that it creates this problem, because now you've got a pre-contoured locking plate that's with a mal-reduced fracture, so it's going to create that issue. And then there's of course some interfragmentary screws. Yeah.
Yep.
So
Jitesh, sorry, got one more?
Yogesh?
Yep.
Actually, for you, the question, Steve, I wanted to know why you think a lock construct would be doomed to fail. I understand if you make the construct too stiff and break the rules sort of thing, then it's bound to fail. In this case, I would say there's too many errors, right? So it's bound to fail.
Sure.
But say you did a sort of like a near-far screw construct with locking even, would you still say it's doomed to fail? That's what I do.
I wouldn't say it's as doomed to fail, but I have worries in fragility skeletons that you're making it too rigid by going all locked. And I think even if you look at the quality of the diaphyseal bone in the elderly, the cortical thickness isn't that different to a younger patient. If it works for you, carry on doing what you're doing, absolutely. For me, I just worry that in that group of patients where you want rapid callus, that I just find the hybrid gives me slightly better biomechanics. I don't know. I mean, we'll throw that on. Who does all locked constructs? If you're doing a lateral plate for these distal femurs in the elderly, who's going all locked constructs? Couple.
Let's
Okay.
be honest.
And
I think quite a lot of you.
Who's doing hybrids?
Mhm.
So locked distal, non-locked proximal.
Okay.
Okay. And who's too frightened to put their hand up? The rest? No? Okay. Who just changes their mind with it? Yeah. So, you've just got to have something that works in your hands and makes sense. So for me, I just worry about it being too stiff. And that may be just because I've seen failures referred, and biomechanically for me, I think it's possibly not right. But yeah, of course.
Someone mentioned a medial plate.
Yeah.
I've seen it in the AOS and things like that, but I can't find an indication where I would say, okay, for certain I'd use it. In fact, the Americans, as far as I understand, they supplement a lateral plate with an additional mini medial plate. But having not found a problem to solve with that, I'm not sure if anybody has an indication for it. Somebody mentioned it, maybe they
Yeah.
tell us.
So I think you mentioned doing medial plates. Have you got any particular, fracture pattern, any particular case that you would tend to want to use a medial plate?
Yeah, most when you have medial comminution, that's when I use it.
Okay, so
Yeah.
medial comminution. Yeah. Anybody else using medial plates in specific cases? I mean, I don't think any of us do them regularly, but any particular ones?
I think you mentioned one. Oh, there's a mic. You mentioned one.
Yeah, also looking at the, where's that, where there's a page on-
Do you have the post-op? Yeah, perfect.
looking at that spike that is on the medial side, if it's from the distal fragment going up, that is bound to slide up. If it's from the proximal shaft going down, it may not work, but in this one, it's good because once you load that knee, that spike is going to go up. They're looking at the fracture line.
Yeah, so for me, it's, medial comminution is potential, but for me, it's these that are called the reverse oblique, where the exit is high medially. So with all the fixation laterally is quite stiff, but the shear force is all exiting medially. And I just worry about, they'll just fail into varus. And it doesn't have to be anything big or clever. You can just put a simple DCP, just something to capture the apex. The one pre-contoured plate that fits beautifully is the lateral proximal tibial plate from the same side. So if you look at the curve of the proximal tibia flipped, it's the perfect match for the medial distal femur. It's just a little 3 centimeter incision, perk, and you just slide it up. And then in terms of your diaphyseal fixation, if you measure Lesser-Trock to medial epicondyle, 60% of that, the distal 60%, is safe in terms of the artery for percutaneous fixation. So, you can get quite a good length up there. Or if I can do, my preference is to do a plate nail combination for those. So if I see that medial comminution or that sort of reverse oblique, and the morphology is suitable, I'll do a plate nail combo. But if not, if it's too distal to get a good fix, I'll think about a medial plate. So it's minority cases, but a few sort of relatively specific indications, I guess. Sorry, Jess. Yep, one more. Yeah, if you grab the mic.
If I may ask, from the time of injury to fixation, what was the time frame? Because we tend to operate these cases late, as compared to fresh. And then another one, the position of the patients. Because these ones, if they are done early, then you put them on traction, they tend to work better than if you just put them supine, especially the fresh ones. The old ones, those ones, traction might not work at that level.
Yeah, look, it's about 4 to 6 weeks post-injury that this patient was operated on, and I can't give you the exact date, but that's often the case. Like you say, you don't get a great reduction. I don't think this one really needed traction. I think if you did it on a normal radiolucent table, you did maybe a swashbuckler approach and reduced that articular segment and plated it, should have been fine, and then added a medial plate. But something just to highlight here about the cortical fixation, like Steve said, she does have good cortical bone up there, even though she's osteoporotic, and that's where it comes in that if you're putting a locking plate, you can use non-lock screws at the top. And there's also some more recent studies that have shown far cortical locking. So there's far cortical locking screws. I don't know if you've used them, Steve, but they lock into the far cortex and they don't lock into the lateral cortex. And that essentially locks into the plate, doesn't lock into the lateral cortex, but locks into the far cortex. And how that works is they find that when you have this stiff construct on the lateral side, the degree of micromotion on the lateral side is not equal to the micromotion on the medial side. So you're creating a construct that has, you're going to get asymmetrical callus formation or healing, and can lead to non-union. So they theorize that if you use locking on the screw locking onto the far cortex, that it would even out the forces that are at the fracture site. Do you ever use them, Steve?
No, I mean, I look at those similar to what you were talking about. It's a solution to a problem I don't have. For me, I think it's a bit of a gimmick.
Yeah.
A lot of it for me, the vast majority of these, I'll be nailing them anyway.
Yeah.
So I don't do huge numbers of plates. For those of you who are plating these, how long are you going with your plate? Anyone? Halfway, 2/3 of the way, all the way, as long as you can, really short? Yeah, do you want to grab the mic?
All the way up to the level of the lesser trochanter.
Yep. Okay. Anybody else? Anything different? So I think long plates, big biomechanical advantages. You know, the screw density is optimized, the working length's better. So the one that I tend to do often is just contour the plate around the flare of the trochanter and then stick one or two of the top screws up the neck, just because I know that's going to be the next injury. Because you know this is a population who are going to keep falling.
Yeah.
So just a small request to Smith+Nephew, if you can do plates with slightly smaller gaps between them, rather than the 5 centimeters that everybody does. You know, it's kind of it's out the wound or it's too short.
Steve?
Yeah.
I love the way everybody's going, yeah.
Steve, sorry. Sorry, one question.
Yeah, sorry.
Okay, if your plate doesn't go up all the way, the advantage of that is your wound exposure is much less. Of course, if you're using the minimally invasive.
Yeah,
it may
I mean,
but
you do a perk anyway.
But anyway, just if your plate's a bit shorter, what I tend to do is I try to put a unicortical screw at the top to avoid the stress riser.
It's almost just to try and fade things out.
Is that okay?
Yeah, I mean, you can do. I think for me, my worry is that I know this patient's going to fall again. So I think if you've got a bicortical, no screw, unicortical, it's still the stress is all at the tip of the plate. So I think it's anything you can do to minimize the risk is good. But for me, I'll tend to contour and put something up the neck.
Okay, thanks.
Okay?
All right, so these are bad x-rays, but they oblique x-rays, and I just added them in because it just shows the point that we initially on the AP thought that the screws were not long, but they actually are long. That's because of the trapezoidal shape of the distal femur, so you need to be careful of that because it can often cause medial irritation. So this was initial, I think, 6 weeks post-op, and then she went on to fail. And any comments on that? Let's see what you think. Anyone? Yeah. Table 5, maybe? Yeah.
Do you think it's time for Boggy?
No, this.
Yeah. Can you hear me? Failed. This is fatigue failure, so there was no union going on, so the implant had to fail. Union, but it's varus now. Fatigue failure, yeah.
Yeah, okay, so yeah, we agree the plate has failed because the fractures attempted to heal, there's lots of callus forming, but it's not healing, and then we've got, of course, varus collapse, so you've got this large fragment that we identified initially that wasn't really fixed, and you can see how displaced it is there. So you now have this problem, it's varus, it's collapsed, the plate is broken. Let's just go on. Yeah, she's got mild pain, actually not too bad, walking around, no crutches, and clinical varus deformity and flexion. And the wound is well healed, there's no signs of infection there, but markers are raised, which we often see in retroviral patients or immunocompromised patients. It can be from other causes, but you don't have a definitive sort of idea of whether this is infected or not. So CD4 counts 320, the wound is healed. What are you going to do now? So any thoughts? See maybe the lady next to you, so you can.
I think it's still on. So I think because the patient is immunocompromised, even though you don't suspect sepsis, we must exclude it. I'm assuming that we did try and optimize the patient with regards to their RVD management in the first setting.
Yeah.
But if we didn't, we should. With regards, so basically first optimize the host, exclude sepsis. But then with regards to the fixation, So I think it also failed because it wasn't, there wasn't mechanical alignment in the first place. So we do have to address that. I think we should take out the hardware, then if possible or ideally get a CT scan so we can know which parts have united, which parts haven't, because it was a fracture with comminution. And the options, I still think we could replate because our mode of fixation wasn't adequate. So we were using a good fixation, but we didn't do it properly. But if the condyles were united, according to the CT, we could do a retrograde nail and span the whole femur.
I think now we'd
but I would
probably stay away from nailing because it's completely displaced on that medial side. Yeah, look, there's many options. Who would do a CT first? Is it something you'd consider, or yeah, it's not a bad idea. Okay, you could get a CT scan. I don't have one, but you could get a CT scan.
Those of you who are going for a CT, can I ask what are you looking for particularly?
Yeah, I just want to look at that the joint line, as well as I want to look at that fragment that's you can see it on the lateral, that's sort of subluxing posteriorly. There is some callus formation as well, but I think I just want to see where exactly I can place my future screws.
Yeah, so basically, is there an interarticular malunion? And I guess entry point, if you are thinking about nail, what's your access going to be like, and how's that going to turn into reduction? So yeah, no, I think they're really good reasons if you're thinking that way.
Okay. And okay, so I think we all. I'm not going to. This is not an infection talk, but so we're not going to go into the details of how to work this patient up. Of course, just one thing to mention is that distal femur fractures, if they technically intra-articular implants. So if they have an effusion, that's one easy way of doing a test. You can do an MCNS, just aspirate the knee. But again, here you'd need to exclude infection. You could consider two-stage approach, remove plate. Like you said, if you have a CT scan, then decide on your fixation. Steve, would you still try and nail this? Is that something?
I think it would depend on what the CT looked like.
Yeah.
So I think if the intra-articular malreduction hadn't healed,
yeah,
I'd be quite tempted to nail it. I think if it had healed and I couldn't get access, I think the prospect of doing an intra-articular takedown at this stage in this patient, I wouldn't.
Yeah, so the general consensus is that these intra-articular fractures do heal. So it's that intra-articular split that normally heals, and it's the metaphyseal fragment that will not heal, and then you end up with fatigue failure of the plate. So yeah, that is an option. So yeah, don't have any post-ops of those, but I just wanted to use that case to highlight some of the issues. Pakamani, yeah?
No, I just wanted to comment on the fracture biology. So with this one, the biology is there, so the fracture wants to unite.
Correct.
The problem from the beginning was the stability of the fracture.
Yeah.
And with that medial comminution, on the first or on the index procedure, they should have considered the medial plating for that fracture. What is also gaining popularity with these distal femurs is especially with this osteoporotic one, is the intramedullary fixation supplemented with the plate in some instances. So I'm seeing that trending around as well. So with the distal femur non-union, or this case is not really like a non-union by definition, but with the biology that is there, probably double plating for me will be the go-to. Remove the lateral plate, correct the deformity, and do the double plating lateral and medial, because the biology is there, and it's just the stability that needs to be provided.
Yeah, so that's a good point, Pakamani. I think when you're dealing with non-unions, and he's going to give some talks on that, it's just deciding upfront, is this a biology issue or is it a stability issue? I mean, one of the delegates said that it was mechanical alignment. It's not really, it's mechanical stability and alignment. So the stability of the construct was not correct. You have to change that, and then you see how that is going to get it to heal. So I just put this slide up because I think this is a good article. If you have some time, you must try and get your hands on it, read about it. They give you quite a lot of tips and tricks on distal femur plating and you know how to position your patient, what's the optimal plate positioning, and they also talk about what implants to use. And in that article, again, they just these are just pictures from there where it shows that, you know, if you have good intra-articular exposure, you'll often be able to identify even the Hoffer fracture, and you can clamp it, fixate it prior to plating it. If you're just using the lateral approach, then you don't get this amount of exposure. You're unable to see exactly what is in the knee joint, and you don't know whether that's going to be fixed or not. Then they also talk about, again, using supplemental fixation. And like I said in the previous, showed you in the previous slides, the view determines how long your screws are. So if you're looking at a 20 to 25 degree internally rotated image, you can see that the one screw is quite long. So it's important to get your screw length. Like we've discussed in, about all the different types of plating, they go into detail on many different options, and like Pakamani said, nailing is supplemental nailing with plating is a good option. And then they also talk about here where you see a nice medial plate and a lateral plate. The medial plates, you're using the opposite side, is the same side lateral tibial plateau plate. There's some authors who also use a proximal humerus plate, or you just take in a recon plate and bend it, and if it's something that's going to supplement your fixation. Okay, and then we spoke about medial plating. Again, if you want to see more into the course of the femoral artery, this is also a good paper you can look at. It shows you exactly where it crosses, the distance from your adductor tubercle, and also the issue of bleeding comes in with your descending geniculate artery on the medial side. So there's some nice, they did a CT scan study, and you can see there that it crosses over, and most of this area is a safe zone. It's just that, you may encounter some bleeding with your descending geniculate artery. So if you are medial plating, you have to be familiar with the anatomy. So let's do case 2. It's a 31-year-old MVA polytrauma. Yeah?
You have 5 minutes?
Yeah? Okay, cool. So MVA polytrauma, no comorbidities, lower limb fractures, had an open distal femur, chest, abdomen, spine was normal, and HB was 7. So this is the CT scan. We do see these patients quite often. You can see that this distal femur is comminuted, very displaced, and he's got an opposite femur fracture. Now, this patient had an interesting injury around the ankle as well, where the talus, it was a talar fracture dislocation. You can see it sitting at the back, and a medial malleolus as well. So something that excites Steve. So yeah.
It's all mine.
So yeah, these are the x-rays post-op. Anyone wants to comment? So initially he was resuscitated. He had a spanning external fixator, debridement of the wound, and we went back in, I think 48 hours later. Patient was stable enough for definitive fixation, and this is what happened. Okay, so it was nailed. It's segmental. Some debate on whether that will heal or not, because it's a devascularized segment potentially. This was a closed fracture, so it was left alone to see what happens. This side was the open fracture, and The wound was fine. There was no issues with any comments from the crowd. It's table 12. Let's see, anyone?
Yeah, so I'm worried about the same sort of fracture pattern. If you look at the view on the right-hand side, that medial condyle there is still basically loose. You've got it's highly comminuted, which is the difference with the previous one. So it's not a simple case as putting a medial plate there, but I think the medial condyle is a worry there. It's intra-articular, and you haven't got adequate fixation on that medial side, so I think it's going to collapse again. So that's the worry there. Look, it's all's fair in love and war. I mean, we know it's a terrible patient. It was an open fracture, etc. So hindsight's always 20/20, but I still think that medial condyle is not fixed at all. I think that's the worry there for me.
Okay, what do you think about this view where you're seeing quite a bit of that notch? What does that tell you?
There's either a rotational issue there, or it's not adequately fixed. You know, I don't think it's anatomically fixed there. There's also a lot of comminution, so it's difficult to see.
Anyone else? Does anyone know what causes that, or why do you see that on X-ray? Kamlesh, yeah.
The distal fragment is in recavatum.
Yeah, so hyperextension of your distal fragment. So if you see that on X-ray when you're fixing these, and you can see, they often say that when you want to compare your fixation, just screen the opposite knee, okay? See what it looks like on the table in the position that you have, and then it'll tell you that this fragment, the articular block, is actually slightly hyperextended. And this, I mean, it's highly comminuted. It is difficult. It is a challenge to get this fixed to match the opposite side. It is in a bit of valgus, which, you know, it tells you that these screws aren't really, you know, in line with the joint. And there's another deformity that's kind of formed here. Does anyone know what that is? Where you get medialization of this fragment. Okay, you've heard of the term golf club deformity. Okay, so it does happen where this fragment gets slightly medialized. That's got to do with how your plate is placed on your lateral view, as well as hyperextension and posterior displacement. So what do you think about these screws? So it's 5 screws, maybe too many. There's 1 screw, I don't know, that was probably used to get the plate onto bone. And these are all locking, again, probably incorrect. It's a young male. You should not be using that many. You could use non-locking screws. And you can't see under the plate, but there is a screw there that's that was used initially to fixate the articular segment, and there was obviously some bone loss because it's an open injury. You can see that the articular surface has fragments that are missing, so they weren't able to get a proper articular reduction. Okay, so
I'll just ask if anybody would have thought about shortening that up a little bit through the open fracture just to try and improve the contact. You know, completely agree that's all really unstable medially. Anybody think about just maybe shortening it a few centimeters to improve the bone contact? Just me.
Yeah, it's an option, certainly, yeah.
And just one point, on the left, who'd have put screws up the neck for that injury? Routinely, who'd put screws up the neck? Anyone? No? So what's the incidence of neck fractures? High energy segmental femur? Maybe?
Oh, in these cases where you've got high energy femur fractures like this one, it's about 10%, but 30% of those are missed.
Yeah, so it's relatively high, and I think for the time it takes to put a couple of screws at the neck and the potential catastrophic outcome of missing it, for me, routinely I'd put screws at the neck in these, but.
Yeah, I agree. It definitely needed a a Kevlar Madari nail. Okay, let's just look at some of the other images. This is at 6 weeks. It's not projecting too good. The lateral, it's not terrible. I mean, considering the original injury, there's a lot of comminution here. Is there anything else you could have added in there to supplement fixation? Would anyone have bone grafted this or done anything else? Or
Nail.
Yeah. Pakamani, you? Bone graft? Are you a fan?
I wouldn't have to bone graft initially, just a medial plate and see what happens, and then maybe if I need to bone graft later, then consider bone graft.
I don't know if a medial plate would have changed too much because it's, I mean, you'd have to get well, where are you going to put your plate and how high are you going to go? Because it's really, I don't know.
Jitesh, I think I'm not a big fan of nailing and plating, but in this case where I see such a large defect and the plate is taking a lot of strain, this is like a bridging plate, and there's a high chance of the implant failing, I would consider a nail and a plate in this one, but very rarely do I do that. And then I would also, if I do open the fracture site, I would consider putting in some bone graft there, some allograft, because the whole point of it is for the biology to win here. So I would, while I'm there, I would put some bone graft.
Yeah, I think it's not really something. I asked the question deliberately because I think it's been found not to be too useful. If you've got a massive defect, of course, then you want to use a spacer like cement spacer. But yeah, I think leaving the tissue envelope alone, yeah. Okay. And then these are just X-rays. The knee joint, it doesn't look too bad on this skyline view. Even with all that comminution and bone loss, that little anchor in the patella was to fix that distal patella fracture. The talus, of course, will end up in with AVN, but it's 100% AVN rate.
Man, you've got to give it a chance.
Yeah,
got to love it and treat it with respect. It'll behave.
Yeah. Yeah, and then
you got the Taylor's fan club here.
Yeah. Okay, and then this is now at 4 months. I started to form some callus up there. It's this area is still looking like there's not much happening, and plate still looks okay. Are you going to intervene at this stage? Would you do anything? No. Okay, so just see what happens. Is that everyone's consensus?
You're saying it's 4 months. Is there any evidence of healing, bridging trabeculi?
There is. If you look closely, there's a little bit of callus up there, and it's also on the lateral view, a little bit here.
Any symptoms?
No pain. He's walking. He's got good range of motion. Yeah.
One of those things, you know, patient's got no pain, they're walking. I can only make it worse.
Yeah.
Don't poke the bear.
Okay, so I wouldn't do anything. I would leave it alone, see what happens. And I think what Rakesh said there, you could have considered a nail initially as your primary fixation. Extreme nailing would have been a good option. But yeah, let's see what happens. Okay, so just again from that article, you can read this, but running out of time. But yeah, it gives you some idea of where you should place your plate to avoid that golf club deformity, and again, just to ensure that your plate sits anatomically on the distal femur. And then this slide again just shows you what I mentioned about the notch view, indicating that there's hyperextension of your distal fragment. Do we have time? Just one more case? No?
Sorry.
Okay.
Cool. That's fantastic. Thanks, Jitesh.
Thank you.
You're up, my friend. Okay, so we're going to move on.
That's excellent.
Yeah.
All right.
Yeah. So on that case, I'd have put Kevlar medullary fixation, so I'd put screws up the neck in the nail routinely. But I think a younger patient, if I'm doing a lateral plate, probably a much lower risk. But the fragility group, if I'm lateral plating, I'll contour the plate and put screws up the neck, because just to prevent risk with the next fall. Max, all yours.
All right, thank you, Steve. For those who don't know me, I'm Dr. Mtetwa. I'm the orthopedic consultant, and I'm a tumor and sepsis specialist in KwaZulu-Natal. That's why I've got some septic stuff for you guys to excite you. So just to introduce my talk, I just reflected of what the previous work I did on the chronic osteomyelitis, and especially the post-traumatic infections, which we've revised the term these days. We call it fracture-related infection. And we can see there our statistics in our tumor and sepsis unit that most of them, they are like mixed organisms, the post-traumatic ones, and they're mostly sensitive to most of them, they're sensitive to ciprofloxacin. So also to kick off my talk, we treated this young lady. A roof fell on her during the KZN floods in 2022. And she was polytrauma. And yeah, she had these fractures. So Steve, we had very bad floods in KwaZulu-Natal in 2022. I think about 43 people died, I think, on the, yes. So she was one of the flood victims, the natural disaster. Okay, I'm not too sure which table we haven't had speakers. Maybe that table there, Cynthia.
I think it's time, isn't it?
Yes, yeah. So she had open fractures, both femurs and the tibia. Castillo Anderson 3,
oh, okay.
3B, yeah.
All right. It's a patient with very severe injuries, segmental tibia, fracture open, as well as on the left side, also distal femur fracture, comminuted with an extension, looks like into the joint. So I think the priorities with this patient would be the contamination, which you can see on the X-ray there. So the initial treatment would be to debride as much as we can and span the fractures with an external fixator, and offer prophylactic antibiotics. And I think in this case, probably before we even get to definitive fixation, the patient would need probably more than one debridement and with external fixation temporarily.
Okay, thank you, Doc.
Hello. Okay. Do you have an X-ray of the pelvis of the whole femur on the left?
Yes, we've got the pelvis so on the same side, on the left-hand side. She's a known patient with rheumatoid. She had hip replacement on the same side, on the left.
For me, I will debride the left leg and put the external fixator. Also debride the femur. Let's see. Another thing, I'll give antibiotics. Once the patient and the wounds have been stabilized, that's when I'll go and I take the femur. I'm not sure if there is an intra-articular extension on the distal femur. I will have to have some proper images again.
Okay, all right. So who in the open fractures, who still do debridement, external fixator initially? Who does debridement and internal fixation in open fractures in the first setting? So who does external fixation in the first setting? Okay, that's interesting. All right. Okay. So, yeah, she was unstable. We were preparing her to get to ICU. We went in. So this is what we did on the first setting. So I think she became, we did firstly a debridement, and then we inserted the intramedullary fixation for her, for both the tibia as well as the external fixator, right? So when we did the up and down nails, she was, as I said, she was unstable, and this is why I brought these x-rays, so that you can look at the x-rays. Okay. Then she went to ICU afterwards. Okay, anyone to comment on the fixation? Yes, Dr. Ketty?
I think to answer your question when you said who does external fixation and who does the nailing primarily, you know, I do both, but I think it's the matter of looking at the host, look at especially the mechanism of injury. When you talk about the floods in Durban and you have a patient with a compound fracture, obviously, I mean, there's dirty water there, there's storage and everything. This is the patient that I would go debride and externally fix first before I go definitive. But then, like I say, I still have those ones that will come with the 3A, and we debride the patient as they come in and put the intramedullary nailing.
Okay, I see Dr. Hetzi is exposing us, the Durban guys, with our dirty waters.
This one of yours, Dr. Hetzi, you're confessing.
I would comment about the distal femur or the femur on the left side. Like you mentioned that the patient has got a replacement done. I'm not happy about the stability. You know, I'm not sure about how many screws you have up there. But yeah, it's already in bearers. So the stability is very much questionable for me there. As you can see, even I guess the left tibia looks like it's properly done and it's stable. Yeah, the segmental tibia on the left, oh, it's still the same. All right. Yes, I think I'm not worried about it, but infection still is my concern, since the primary operation was just done without having given the space for external fixation and try to treat infection first before we go in.
Okay, so because, okay, yeah.
Max, can I ask what happened with the open wounds at the time of this operation? Was everything closed or vac sealed?
Yes,
or?
yeah, we had vac dressings on the wounds with a view of contacting our plastic surgeon friend later on to do.
Okay, so not primarily closable, was going to need some sort of soft tissue later.
Yes, okay. Yes, yeah. I saw one hand up there. Yes. So
I
initially,
can't see the distal fibula on the.
Yes, yeah. So initially, the distal fibula, because of those extensive wounds there in the distal fibula, was also lost with the open fracture there, and so it was lost during the accident. So it was excised, some of it, and during the debridement, but some of it, obviously, she had bone loss at that point. All right. So obviously, this is a septic case. Did become septic, and after all of that, debridement, soft tissue covers by the plastic surgeons, and this is now here after like I think it here is like 18 months or 2 years here. And initially, we did use like an antibiotic nail because of the concern of the sepsis that was raised. But even with our better understanding of infection, I think we try and shy away from the external fixators. Even with the open fractures these days, we use internal fixation methods, and then we deal with this. Once the fracture is united, we deal with the sepsis later. So it looks like there she united, and we can see there as well. Dr. Khetsi, do you want to comment on that, on the distal femur?
Okay. Yes, I think she united, but like what we originally seen, that is in valgus. I'm still questioning the unity there. Okay, because you can still see. Yes, we have a bridging callus on the medial side, but you still have the lateral side open. So I wonder how, what symptoms the patient has at the moment. And you said it's also septic. Did you say the distal femur is also septic?
Yes, yeah. So when we removed the implant there on the distal femur, we did a debridement for the sepsis using a Lautenbach procedure here, and we left the hip replacement in situ. So the traditional teaching is that you'll have to remove the hip replacement as well, and deal with the sepsis, and then you can go redo reimplantation. But in this case here, we decided to deal with the fractures first, get union, get rehabilitation, optimize the host, then we will deal with other issues later. All right. So she's got up to 30 degrees of movement of the knee. So that was also our discussion initially, because once you have a patient that you have fixed, now is in ICU, you're allowing the plastic surgeon to do all sorts of things with the external fixator, then you end up with this, a stiff joint with the knee spanning external fixator. So that is why one of the decisions that we made is to fix the fractures, and at least to get some physio with the movements of the knee initially while she's in ICU, so that whatever happens, at least she does have some movements of the knee. Okay, so I think the concern was the sepsis here. Obviously, we saw some heavy growth, but fortunately for her, anyone wants to comment about the microbiology results here? Can everyone see? You can look at your screens as well. Table number 12. Do you guys have anything to say about that micro results?
Well, I think luckily for her in this case, also it's quite sensitive to everything. So I mean, it's not a resistant bug that's been cultured there. Because out of all the bad news, that's probably some of the better news that there's actually something to treat it with.
Yes, yeah. So to just to comment on that, also it's a very interesting case because she also, while she was in ICU, she had that infection of the skin, including like the skin with cultured staphylococcus in the skin, with cultured staphylococcus in the bone, with cultured staphylococcus systemically as well. Okay, so I was trying to find those results of the, but what I'm trying to say here is that it was a sensitive organism, which is quite rare for the fracture-related infection or what we spoke about, the post-traumatic infection, which is also a concern for us that this probably we don't have enough bacterial coverage for her, especially for a patient that also been in ICU. You will expect that at least they have a mixed organism growth. So yeah, that's what I've just mentioned here. So you can see there our results from the trauma and sepsis unit. The post-traumatic infections, they were high here. They were quite significant with like a mixed growth on these ones. And with the bacteria and the host, there was no difference there. And the patient, whether they are HIV positive or not, we did not see any different difference there. Okay, case number 2. 30-year-old female, type A host, car accident, septic post-traumatic non-union tibia with a grade 4 Pintrax sepsis. So this patient here was reconstructed elsewhere after open fracture, bone defect, and he came to see me with these X-rays here. Anyone wants to comment on the external fixator? Grade 4 sepsis with the non-union.
On the X-ray that it's an atrophic non-union, so it's obviously bone biology associated, and it's definitely in a malaligned position. With the fact that it's atrophic, there's a high probability of infection, I think. The external fixator, I'm not going to criticize on that, but I think we definitely have a malunited or malpositioned atrophic non-union there currently.
Okay. Anything that could be done about that? I see they applied the external, the hex support type of external fixator.
I suppose you can go in, do a debridement, and try and realign it slightly better. Depending on the amount of infection that you've got, you might have to either do a resection of those bone ends and do a maculae technique with a bone spacer, and then later go back and do grafting. If you want to go really extreme, you can obviously do lengthening as soon as your infection is eradicated. Or you could just simple, excise the non-union and realign your fracture and then just shorten it.
Okay. So this grade 4 pin check sepsis, are you concerned about anything with the grade 4?
Sorry, Pax, got one more.
Sorry, I missed that one.
Yeah, sorry.
Yeah.
The grade 4, yes.
No,
That changes it
the point
slightly.
I was making is the grade 4 pin track sepsis, if you're using the checkers and upcuts, that's a major infection.
Mm.
So you need to address that by debriding your pin tracks and reciting your pin tracks, because your etiology of your instability is of your sepsis is your instability. So you've got to get a stable construct as part of your first steps to eradicating the infection. So it is the instability that usually comes first for the sepsis.
Yes, yeah. So with the grade 4 pin track sepsis, yes, yeah, that tells you that probably you're worried about the stability of your frame as well. So,
Sorry, I missed the grade 4 pin track. It changes it slightly. And you might even have to go and give the patient fixate a holiday or honeymoon, eradicated before you can go back and attend to it.
okay, I see.
Pax, just a
yes.
question, maybe I missed it. Where's the infection? Is it the pin track infection and also fracture-related infection at the fracture site, or just a pin track infection?
Yes,
Both?
yeah. So as I said, she had the MVA open fracture, distal tibia. They did some reconstruction, and they applied this frame here.
Yeah.
Yeah. But for me, if I treat a patient like this, and I apply external fixator, and I have a grade 4 pin track sepsis, that tells me the infection is all over that long bone. Okay, that tells me the infection is all over here. So that means that whatever I do, I need to address the whole long bone. Okay. So
anybody else thinking about a complete change out? We talked about pin site holidays. Yeah, take the whole frame off.
With the grade 4 pin track, I would take the whole frame off.
Okay, and what would you do for stability once the frames come off?
Good question. I would maybe put the patient in a but I would debride as much as possible. I've got back. I would still probably consider doing a changing my position on my fracture, maybe even shortening that a bit. With the concept of the infection, and I agree it's probably full medullary infection, I would either shorten or use a maculae technique. I would not want to use a bone graft in a situation like that.
Yeah, no, I agree. I think grafts and infections
Here's another
worry me.
hand there.
Yep, the corner.
While the patient's having the holiday, would you consider getting an MRI?
Okay, anybody got any thoughts on that? MRI while they're having their pin site holiday? Or any other imaging you think is going to help? Pax, would you?
No. I don't think the MRI will give me the information I need here. I know the whole tibia is infected, so I just need to go and address it. I know that the frame is probably unstable as well with the pin track sepsis because of the sepsis, and yeah, I think MRI, and also with the metal artifact with the external fixator as well. I know you can do a mass, but in these instances, sometimes like the pins are stainless steel and things like that. So I'll be really concerned with the MRI as well.
Yeah. Is anybody using interim cement rods if they're taking these off? Just sort of homemade cement rods interlocked for a bit of stability. Yeah, so it's quite nice with the, just off the same frame kit, just with a threaded rod, down a chest train tube, done the cement in, and then just put some posts on either end, and they'll take a locking bolt through the holes. It's quite nice, you sort of rear out the canal, and then it's not load bearing, but it'll maintain your rotation and your length. It delivers massive antibiotic dose locally. Just put a bolt in top and bottom. It'll just sort of look after the soft tissues, give you a bit of stability maybe. It's quite nice. I like the idea of the exploration acute shortening. So if anybody's acute shortening, are you doing a corticotomy to re-lengthen at the same operation or waiting?
I wouldn't do the corticotomy at the same setting, but I would definitely prepare my ring fixator with a transport ring incorporated. So I can, as soon as I've got my full union, I can start doing a transport. I wouldn't want to do transport or corticotomy at the same time because I'm still not completely healed at the bottom. So we might actually sit with two problems, do a corticotomy at the same time. You might save some time by doing it at the same sitting, but I wouldn't want to do it. I would stage it and just prepare my rings for it.
Anybody want to go with an acute corticotomy? So if we say we lost a centimetre or two, we do an acute shortening. Anybody going to go for a corticotomy at that operation? And any benefit to it?
Yeah.
Anyone? No?
Yeah.
Yeah?
Yeah, I do that
yeah,
quite
me
a few
too.
years.
Yeah.
I do that quite a lot.
Yeah, and I think it's great for getting that distal site to heal.
Yes, yeah.
You really light the whole bone up, and it's really good to help just burn the infection out as well. So yeah, for me, I think there are some advantages.
Yes, yeah. So I liked what you spoke about, the rodding with the cement. I used to do that a lot, a few years back up until I got the antibiotic nail. Yes, yeah. So same strategy here, remove the frame, did a debridement, and I did not do a non-union site debridement here, okay? I just did a debridement of the pin tracts only, and I gave her a pin sites holiday. And then I went back, and this is what I did for her. Okay. Anyone who have done something, so this now is an antibiotic nail, interlocked nail. So now I resected or debrided the non-union site. And the fragment that you see there, some of you will be concerned, was still attached to the muscle. And I debrided to the bleeding bone. I injected the antibiotic, interlocked the nail, fibular osteotomy. Who would have done the similar thing? Yeah.
Yeah.
And if you do this, also you ream the canal using we use the Lautenbach technique to ream the canal, and make sure that do like a Lautenbach system to make sure that you ream the canal, you debride it properly for the biofilm. I saw one hand.
No, I just agreed with nailing it.
I'm an orthopedic surgeon, but
Sorry?
Okay. I'm saying I'm an orthopedic surgeon, but I'm not so fond of rings. And so if you get pin track like you did, I think this is the route that I'll take. Yes, remove the ring, then you put him in a POP and try to get as much soft tissue healing as you can. Thereafter come to this.
Okay, any other suggestion? All right. Sorry.
Just two questions. I was actually going to ask how you dealt with the infection when you removed frame. So you said you did a Lautenbach at that stage.
No. So when
So you
I
just
just
did
removed the frame,
yeah.
and then I gave her the Pintract holiday, and then I came to do a debridement, which is like almost as the Oxford bone infection Oxford unit, like almost like all one stage. It's like doing all one stage in a one stage setting. Debride the infection, and then you rescrub everything. You use another set, and then on the same setting you come back and you do a fixation.
Yeah, the second question, using antibiotic-coated nails as prophylaxis rather than treatment, what's your opinion on that? So open fracture, infection, using these antibiotic-coated nails instead of nailing with a normal nail?
Yes, yeah. So especially if you're concerned about in high-risk patients, like the previous patient, yes, is my primary or go-to treatment, antibiotic nail. And it's actually, in terms of cost, even it's much better than going double fixation, X-fix, or doing a nail. So if you're doing like an antibiotic nail as well, I think on the first setting with the open fractures, I think it is my go-to, especially if I'm worried about sepsis.
So then is it targeted antibiotics at this stage, or we're just relying on that local high dose or high concentration when we give the when we put in the antibiotic-coated nail?
So with this case, obviously I did the biopsy when I removed the nail, or the external fixator, sorry. Did a biopsy of the pin sites, and then you've got the bacterias, and then when you come back, at least you have an idea what type of bacteria you're dealing with, and then you debride, and then you insert the antibiotic nail. But if you want to do it all at a single stage, if you don't have the bug, then you can still go with a wide antibiotic coverage. Okay, I typically go with the tazocine or meropenem, because you look at two things when you're choosing antibiotic: the broader spectrum sensitivity, as well as the bone penetration. So if you get that bioavailability and at the bone site of the antibiotics as well as sensitivity, I think you can go at the first stage, or all at the single stage for this fracture-related infection, and you can get the treatment. And you must consider using local antibiotics all the time in case of the infection. All right.
Sorry, you said you will take Pintract specimens. When you go and insert the antibiotic nail, would you then take specimens as well, just to confirm that you're still on the right track with the right?
Yes, yes. Every time I go for operation, I take biopsy samples.
Okay. How many would you take?
I take about 5.
Oh, okay.
Yes.
You do histology as well?
I do histology, yes, yeah.
How many of you are doing
actually, at the end of this talk, I've got a patient. I had a patient with TB, which was a surprising fracture-related infection with TB. I see we won't get to her.
Perhaps I talk a lot when it comes to FRIs. So I think just to answer maybe Yenzi's question, so with the antibiotic strategy, it also depends on your operative strategy, as far as I understand it. So the FRI consensus group with Morgenstern, they publish quite a lot. There's an article on recommendations for systemic antibiotics. They also got another article. So depending on what strategy you're doing, so whether you're doing a day debridement antibiotics and implant retention, whether you're doing a implant exchange, whether it's a 1-stage or 2-stage exchange, or an implant removal. So that will also sort of guide what antibiotics you're doing, all right? You want to do a broad spectrum coverage before you get the bug, and then if you're doing an implant removal, then you would do sort of directed osteomyelitis type of treatment for like 6 weeks, non-biofilm coverage. Whereas if you're doing implant retention or implant exchange, then you might need antibiotics with biofilm coverage for a longer time. So it also depends on the surgical strategy that you're doing.
I think
Let me
I
finish
answered
this
a
one,
bit.
it's
I was, for this one specifically, we've exchanged and we've now, we now have a antibiotic-coated nail. So I'm asking, is that specific to the bug, or we just attacking it because it's local antibiotic, so we have a high concentration? Because he had a first setting where he debrided, and now, like you said, we do have a bug that's been cultured.
I think this one is this a gentamicin coated nail, right? So
Yes,
I think that's
yes,
pretty
yes,
much the
yeah.
standard
Normal
one. We use.
gentamicin,
And you'd
okay.
still
Yes.
give systemic antibiotics, which are directed.
Yes.
You
So,
wouldn't give just
yes, yeah. So what is important about this gentamicin, or if the local antibiotics, it's like gentamicin is a gold standard, is that it does not kill only the gram negatives, kills everything. And its MIC, it can be close to almost like 1,000 compared to like the IV antibiotics. So it's very good. So yes, yeah. So this is what we cultured for her. Sensitive, and after that operation, she continuously was oozing at the non-union site. So and her CRPs were not coming down. So I decided to go back and do a DARE procedure, as well as the local antibiotics, which are like these days my cheapest form of gentamicin beads, PMMA beads for her as the local antibiotics. Okay, and this is 6 months post the operation. Okay, she's back to running, no pain. Looks like, to me, that looks like it's united, this non-union. Okay, and she still has the beads there. Right. Any questions?
When you came back this time, Bucks, was she already united when you came now for this second operation?
So after this operation here, she had a draining wound that was not healing. So I went to do a DARE procedure 3 weeks later. And then I left the beads on the soft tissues, and I did a continuous antibiotic, systemic antibiotics as well, and then I left these beads, and she circled.
Like my next immediate question is, what's the elution time of the gentamicin around the nail? If it's united, would you consider then having to remove it? Because then it's just practically sitting there like a normal nail. So when you're going back now the third time, remove Lautenbach, and you don't need to put any form of fixation because it's united. Playing devil's advocate.
Yes, yeah.
I don't know.
So
I don't know the
that's
answer.
the discussion I'm currently having with the patient, because you correctly saying with the infection, first get union, and then we know that we haven't sorted out the infection completely. We can always go back and sort out the infection completely, so that we make sure that the infection is treated. And probably use once we've removed the nail, we can still deploy absorbable local antibiotics inside. And then the UK guys, they use the ceramide beads and deploy, which now we've got in South Africa. We can deploy them inside here after we've done our debridement, and that would be the end of it.
Oh,
Right.
fantastic. Thank you.
Thank you.
Okay, great. Okay, one more question.
All right. Okay.
One more, really quick.
Is it an antibiotic impregnated nail or coated?
Coated.
Is it Smith+Nephew? Who supplies it?
No. We can chat outside this meeting.
It's the company that specializes in providing solutions to problems you never had. with a really, really big price tag in the mountains?
The nail. So I checked the cost of the normal nail and this antibiotic coated nail. I think it was 10 times the cost. So like 8,000 versus 55,000. Yeah.
Cool. Okay, right. We're going to move away from legs up to arms. Craig,
Yep.
over to you. Thank you.
Thank you very much. Good afternoon, everyone. Just following with a simple slide background. Just going to discuss a few humeral shaft fractures. We'll try and get through a few cases. Thanks very much for Smith+Nephew for having me. So the first case is a 32-year-old female. Where I work in Kailicha is very common, a lot of pedestrian vehicle accidents, and she's got an isolated injury to her distal humerus. Just have a poll or a show of hands around the room. How many people would manage this with open reduction internal fixation? Great, great. So I didn't manage it with open reduction internal fixation. So that's my question. So we actually managed her in a Sarmiento type brace, and she united. This is about 10 weeks post injury. She's back to full function, and following on to some work we've done in our unit, we manage. Just because of resource constraints, theatre time, we manage a lot of these fractures in Sarmiento type functional bracing with a fairly strict protocol, and we haven't managed to mimic Sarmiento's results. No one, I think, around the world has, but the results aren't bad. So it was about 80% in the 100 patients we've studied so far have united, and actually it's the distal third fractures that do the best. It's the proximal third, obese patients where the brace doesn't fit, that they do poorly. So yeah, she actually did well. She's back working. So I'll move on. The second case is a 30-year-old man following a motor vehicle accident with an open fracture of his left humerus. And these are his initial X-rays. He's got around a 4 centimeter wound. Would anyone manage this with an intramedullary nail? Has anyone got any experience with retrograde intramedullary nails? Would you consider that here? Obviously not, because the entry is right there. But we'll maybe discuss that a bit later on. But this this patient went on. We did do an open reduction internal fixation. We debrided his wound. It was a 3A fracture. We do have some concerns. Which one's the pointer? About this piece here. But this, he's actually clinically he functioned very well afterwards. He didn't have a sinus. His wound's all healed. But this type of plate, which is obviously there are different types. People are familiar with the J-type plate. This is a Y plate, which is actually modular. It's titanium, and the medial column can come off. It's quite gimmicky in some respects because it can come off, which I've got concerns about its strength. But it is always an option, especially if you want to get down the medial and lateral columns. So we'll move on. I've got a few more. So the third case is a 19-year-old female, again after a pedestrian vehicle accident with a right arm deformity. Now, this was a bit of a discussion at our meeting at the hospital. Segmental here. I was very suspicious that this was a Y-type fracture. Now, my colleague here just said he has struggled to get a CT scan. Our CT scan wasn't working at that stage. We would have liked to get a scan of the elbow. What would people do here? maybe table 8. What would you opt to do here?
I think I'll still treat the distal part because it's an intra-articular fracture. I'll do my bicondylar plating there. And then looking at the proximal fracture as well. So either one of your plates, either your medial or your lateral plate has to be a bit long, and then you can also plate the proximal part, the proximal fracture, but you just need to make sure your plates overlap so you don't create a stress riser. Alternatively, just sort out the the distal fracture, and then put in some cemento brace to sort out and mobilize the proximal bit.
Okay. So if you're going to do a bi-column plate distally, how are you going to approach the humerus proximal?
Oh, that's the thing, because if you want to plate it at the same time.
It does go quite proximal. Do you think you'll get
you're going to struggle to get a plate there of your posterior approach. So that means you either have to do 2 approaches now, or as I said, just sort out your distal and then put in a cemento brace.
Okay. Anyone else? Maybe, table 7?
In my institution, nailing the humerus is actually a taboo unless you've got very specific. So we would plate it. You can go extend the delta pectoral into your anterolateral, put a plate on the proximal part, turn the patient lateral, and plate the distal.
Okay.
Just an extra 30 minutes.
Yeah.
And we don't really look for the overlapping plates. How old is the patient? 30. He's young. Young patients, good bone stock. I wouldn't worry too much about the issue of stress rises because it's more applicable in the more osteoporotic bone.
Yeah. Yes, table 4.
I would be very tempted to treat the distal part with 180 plating and then put a nail down from the top.
Loving that. Loving that.
So
I was hoping somebody was going to say that.
So just to clarify,
I'm so there.
What 180 means different things. I think you're referring to parallel plating. Is that right? Yeah, parallel plating. Yeah, because as opposed to 90. Okay, good. So my feeling was to put a nail down and plate distally. I can throw my colleague under the bus. He said, no, the distal part looks stable. I'm joking. He actually said it's fine if I mention this. But, okay, so he did the nail, and then unfortunately he put 2 screws distally, and then this part split. So he'd got his nail down, but this part started displacing. But remember, the patient's supine. Actually quite tricky to get the plate on when you're fully supine. Doing a distal humerus is now quite described in the elderly to do them supine with a bolster like this and work from the top end because you've got gravity helping you. It's actually, it can work, but when they're completely supine in the center of the bed, it is a bit of a mission. Anyway, this is her 12 weeks down the track. She united fine, but it's a complex injury to deal with. I personally probably would have just plated it first distally and not just done unicortical screws at the proximal end and then put my nail down. But it's all's well that ends well. Okay, next one is a 60-year-old male. Again, another PVA with a right arm injury with 2 separate 3-centimeter lacerations on his arm. And how would anyone manage? How would you manage this from here? It's quite displaced. Not so simple. Okay, so I did a broad plate, and this is the last X-ray I have. As I'm sure a lot of you in the room will know, that follow-up is not always, you don't always get the X-rays, especially when you're doing talks that you want at 6 months, but because of many issues. But who here uses I mean, there are many types of plate described. Who uses a broad plate routinely for the humerus? A 4.5 millimeter plate? Okay. Do you use one with staggered holes, or? Just to give yourself more distance between your screws, okay. Does anyone use 3.5 millimeter plates for the humerus? Small fragment plates. Okay, can I ask you why that is?
Asian population, very narrow humerus. They have the humerus is very narrow. You can't put this plate on it. Because my fear is that you're putting 4 or 5 screws in there, I'm going to end up with a split. So I use the striker one with 3.5 screws, all the way, long plates.
Okay. Interestingly, it's been studied recently, the use of the plate. So there's actually no difference in the current systematic reviews looking at 3.5, 4.5 plates if you apply it correctly. And yeah, I think personally, I still think a 4.5. If you're going to use a narrow plate for a smaller patient, that's probably okay as long as you get 4 screws, proximal and distal. I couldn't get up enough. Couldn't get proximal enough with this one. Yes.
Why did you avoid a nail here?
My feeling was because there was two large wounds communicating here. By the time I debrided that, it was like my exposure was pretty much done, and I was quite worried about a nail with the radial nerve. It's spinning in that central fragment. I think if it was if the wounds were a lot smaller, I wouldn't have had such an issue. With this talk now, reading what I've read, probably a nail is definitely probably where I could have gone. I could have used temporary to get the reduction better. I think it would have been easier with a nail, to be honest. To use a plate, a small plate, and then even remove it once I've got it reduced.
Right. Have you got any, with these sort of very short oblique or transverse, any thoughts on when you would think about adding in a second, sort of a 2/7 strength or a 3/5 plate in these particular fracture patterns? Any thoughts on when to do it?
Probably should have done it here. Might have made it a lot easier on the, especially at the distal fracture. Sorry, excuse me. I'll go back. I have done. I just find access for a second plate in the humerus sometimes very challenging. It's different around a femur. I think if you're going to, it's a lot easier, I think, to get your exposure. Yeah. In these, at this level, the radial nerve's always sort of in your view, especially at that distal fracture line. But yeah. Okay. Any other questions? Any other comments? Yes.
Okay. So the issue of the plates that you use, 4.5 or 3.5, like you say, just to add, it's more the length of the plate that's important. So often the failures that we see is where people put in 3.5 with 3 screws above and below, and it's just not stable fixation. But just to add, these plates, these 4.5s, come in a narrow and a wide one like this, so you can customize it to the bone. Would you have considered a proximal humerus plate that spans the entire humerus? You do get ones that start laterally and then go anteriorly, and that would have given you better proximal fixation. Yeah.
Yes, yeah, and yeah, it possibly would, but it's not as thick proximal. That's also, you sort of rob Peter to pay Paul. I don't know. I could have, maybe should have. We'll come to that. I've got another case. Okay. Yes.
ischia approach on that patient?
Yeah, I did an anterolateral approach. The 2 wounds were here on the lateral arm, and I did an extended, sort of the distal end of the delta pectoral and extend it down to an anterolateral.
You split the brachialis.
Yeah. Yeah. I'll move on. Case 5 is a 32-year-old female. Again, it almost sounds like a broken record, but PVA with an isolated injury to the right distal humerus, very similar to the one we had earlier. How would people approach this? Are people doing a tricep split, or are they doing tricep sparing, or how would most people? A show of hands, how many people would just split the triceps and put the plate on? Okay, so, and a lot of people would go paratricipital, is that right? Yeah, okay. So, yeah, also managed it non-operatively, seemed to go okay. Case 6 is a 72-year-old lady, so we'll step off a little bit. Painful shoulder after a fall 3 months prior in another state. She comes in with this. She's a very stoic lady. She says it's a little bit sore. She would like me to help her. What would people do with this? Clearly, she's got evidence of rotator cuff arthropathy, so not a great shoulder. Maybe table 12 at the back there. How would you approach this?
Sorry, could you please just repeat the age of the patient?
72-year-old lady with no medical comorbidities, lives with her daughter. So, she has a painful arm after a fall 3 months ago and hasn't had any treatment. But she's sore and she feels a bit lumpy at the top.
I think my approach is go with the fixation with the proximal humeral.
Okay.
Waiting for that.
What sort of plate would you use for her?
I would use the Pylos plate.
What was that? The EVOS plate, was it?
It was the Evo Phylos.
Okay. All right. So, any particular concerns in fixation with this? Yes.
Oh, I'm a bit concerned about a plate there. First, it's osteoporotic. Secondly, that's her new shoulder joint. I think everything on the top is stiff.
Fair comment. Any other questions? Table 5 or just behind, sorry. Any? What would you do here? Okay. Would you consider using bone graft for this?
How are you fixing it?
Okay. So I used the EVOS plate, and probably one of the happiest patients I've ever had, actually. It was very difficult to actually reduce. The radial nerve was trying to skewer itself distally, and I kept it short because I think I agree with you, we may well be back with this lady. So any comments on the fixation proximally, or Steve?
Yeah, plenty of screws in there.
She was very, very osteopenic.
That looks good. Was how mobile was the proximal fragment? I thought it was a really good comment that somebody made on the far side about how stiff that shoulder was going to be.
Yeah.
Were you kind of rebuilding the arm back onto
It was
a
stiff.
stiff humeral head?
It was stiff.
Yeah.
I always get worried about pulling off the axillary artery when it's that stiff proximally. So I've never done that, but it's well described. But yeah, it took a bit of persuasion. Yeah.
How mobile was she after this?
She was very happy. She was moving her arm as more than she had done for 3 months. That's for sure. She was the happiest patient. She doesn't actually want to see me again. So, yeah. Okay, I'll move on. 28-year-old lady, again with a PVA, closed injury to her right arm. Very, very short. What would people do here? Plate. Or if. Okay. Would anyone do a humeral nail here? Yeah, okay. So I think we did a humeral nail. It seemed to go okay. I guess the current literature looking at nails versus ORIF is changed a bit, looking at the highest level of evidence we've got. So for union rate seems to be better with nails. It's a quicker operation and with less blood loss, but it is more expensive. And I think we've got to keep the costs into play with what we do.
How are you setting up, those of you who are humeral nailing? Any tips and tricks about setup for humeral nailing? Anybody put their hand up for nailing that one? Just how you'd set them up. You know, any tips on positioning, reduction, that kind of thing from the nailers? Supine? Yeah. Everyone gone supine now? Yeah. Anybody still doing beach chair? No? Yeah. Yeah. Yeah, but I think the vast majority has switched on to supine now. Anyone done it lateral? So I've got a couple of colleagues who've talked about locking it lateral, so they can do the distal lock from the back. So you don't have to make a little open, worry about the nerve. But I've not tried it, but anyone done lateral? No?
So they do it lateral and they go lateral to medial locking?
Yeah, so instead of doing the AP lock,
yeah,
they do use the same hole, but just do it from the back.
Okay.
Just shoot it through from the back, but seems a bit overcomplicated to me.
Yeah, no, supine all the way. Okay, I'll move on. I've got a few more. So I've got a 34-year-old male PVA with an open humeral shaft fracture and a contralateral both bone forearm fracture. Who would do a nail here? Okay, still. How good do you think your nail fixation would be here? Obviously, the X-rays are quite deceptive. It looks super wide. I don't know why. It's some sort of weird shoot through, but okay. That was what she had on the other side. So I didn't. I did a plate because of the open fracture. I wanted to bride it, make sure I didn't trap it in. That was my previous thinking. Now that I've done a lot of reading, I would probably also nail this. But I don't think it's wrong to do an ORIF. I mean, the plates are a lot cheaper, but that discussion's really up for debate. This was at 10 weeks. So it hasn't fully united, and haven't got any follow-up X-rays from him since that. Got a couple more. 54-year-old man with a gunshot to his right arm with 2 wounds, with his radial nerve that's intact. Who would do what with this? Would everyone plate? What would you do? Huh?
Yep, we've got one here, Greg.
Huh? Yeah?
One on the line. Yeah. I would. It's a gunshot wound. Massively comminuted. They usually heal quite well. I would.
Like a plate?
Sarmiento brace.
Sarmiento brace.
Functional bracing. Yeah.
Yeah. So we did go with a Sarmiento brace initially, and this is at 3 months. So there's been some healing, which is good, but arms flopping around a bit in clinic when you take the brace off.
What's happening with the wound and the soft tissues?
All healed. Wounds all healed.
Interesting is it seems to be an atrophic non-union.
Mm.
So it's obviously bone biology.
Mm.
So I'm not convinced that the functional bracing was the cause of the non-union. It's probably more bone biology.
Mm.
Which is very rare because gunshot wounds actually do heal quite well. Now it becomes a bit of a obviously need to respond. And I would personally now go in, debride, take specimens, make sure that there's no infection, and I would even contemplate shortening that humerus a bit. There's nothing wrong with a slightly shortened humerus to try and get your union established.
How much shortening would you accept in this?
Well, the guys say you can accept up to 3 centimeters. I don't think you need to go that far. I would say 1.5 to 2 centimeters should give you enough shortening, and if you augment it with some grafting, I think, and decent stable plating, you should be able to get it to unite.
Yep.
Okay, so if you're plating 1 plate, 2 plates?
I would go for the 1 plate technique.
And whereabouts?
And I would use the hockey stick plate, the J plate.
Okay. So the extra-articular
yes,
distal humeral.
I want to try and get as far distally as possible.
Yep.
And obviously I want to go up as high as possible just to the functional length or working length of the plate.
And autograft?
Yes.
Yeah.
Although there is a lot to be said, because the donor side usually is more painful than the operation side. But yes, I would go for auto.
Okay. So anybody got any other thoughts? So we've got acute shortening, single plate with graft. Anybody want to do something different? Yep.
The acute shortening and then the hockey plate, but I also put a short medial plate.
Second plate as well?
Dual plate.
Okay, and grafting or not?
Definitely.
Definitely grafting?
Definitely, Alia crest.
Okay. Hitesh?
It is fine. That's my implant of choice. But I think just to comment that these gunshot wounds, if you go in acutely, you'll find that you would end up with much more bone loss than what you would end up with at this stage. So I often just leave them like you did in a brace and let them, let's see what heals off those fragments. And then when you do your secondary procedure now, your shortening is a lot less. It's more predictable. If you had to go in initially, all that bone would just be
It's just a
fragments.
mess acutely.
Yeah.
You just think I've just got to bridge this, and you actually.
So, I mean, I don't know if I'm doing what's the correct thing. Would anyone go acutely on this? Anyone at all? No.
Yeah. Acute infix, yeah.
Yeah, I would have gone acutely with a hockey stick plate, then shorten.
Okay. So.
Sorry, you see what happens? they lose a lot of time. We never discuss this with the patient, or mostly we ignore it. We lose a lot of time for rehabilitation purposes that they could have been using for working or sports, etc. I'm included there. So I don't want to waste time when I have an injury, given the circumstances. Yeah, it depends on the personality of the fracture, etc., etc. So if we save a little bit of time, why not? So always discuss with the patients. We underestimate that a lot.
That's a good point. Thanks. So I did go in. I did use a J plate, and yeah, I didn't graft him. I drilled the both ends. It was very vascular, and this is the X-ray. So you can see this piece here, anterior medially, which also was a bit loose, but I shortened it as much as I could. He actually did quite well. So this is, I think this is at 3 months after. He didn't have any pain. He was back working, and I haven't seen him since. I think it is healing, but yeah, I guess I'll never know. Any comments?
The best follow-up, right?
Yeah, it's very hard to do it.
I mean, it's great when they don't come back sometimes, right?
So I think everyone did what I probably would have done. Case 10. I've got a couple more. I've got 10 minutes, have I? 29-year-old.
5.
Oh, 5.
5.
Okay. 29-year-old cashier with a closed left humeral shaft fracture. This, would anyone manage this in a brace? Would anyone nail this straight away? Anyone plate it? Everyone's going for a brace. Good. So this was at 2 in the morning, and the EC put up a U-slab. And everyone's sort of chuckling because this is actually not uncommon that they put on back slabs and they make things worse. But so we saw her at 8 in the morning, and she came in. Everything was documented. Everything was on the referral was neurovascularly intact. Now the radial nerve is not intact. What would you do now? Would anyone still continue with the brace? Okay.
Yep. Yeah. I'm saying if this is done at 2 in the morning, well, you come in the morning, it's like this. You just sit the patient up and reapply a proper modified shoulder splint.
Okay.
As a first step.
Yeah. So it was reapplied, and it looked like that. And still got a dense radial nerve palsy. What would you do now? Yeah.
My question is, was it undocumented? Did someone actually check correctly that it was actually intact to start off with?
That's a good point. Excellent point. Yes, someone very experienced.
I think I'll still give it at least 6 weeks and see what happens. If nothing has happened in 6 weeks, then I'll go explore.
Okay. Steve, what would you do with this?
Probably the same. I think I'll probably sit tight and see whether it recovered.
Well, I didn't. I actually explored this, and the radial nerve was entrapped in the fracture site at this level, between the second and third screws, proximal. And it was almost so the spike had actually pierced the nerve almost in 2. Yeah, so it's very, very rare. Yes.
Sorry, it seems that I'm getting verbal diarrhea here. The interesting thing is you said that it was initially charted that it was intact.
Yeah. Then the U-slab was put on, or attempted U-slab.
Yeah. And I would have done exactly the same. I would have gone in and explored it, because it suddenly becomes a medico-legal issue. An intact nerve, the following day it becomes a radial nerve fallout. Now it becomes a medico-legal issue. So according to me, you need to go and explore, because you need to try and find out where that nerve... It could have been documented wrong the first time, but it has been documented. So it unfortunately is a medico-legal issue. You have to go in and explore it and remove it and plate it. That's my opinion. I would have done the same.
Yeah.
Okay, so quick show of hands. Who'd have left it to see if it recovered? Who'd have given it a chance? Nobody? So you'd all go in and explore and fix? Yeah? Okay.
Yes, sir.
I think the one nerve that you can't miss is the radial nerve, and it's very easy to examine. So if it changes, you're obliged to go and explore. Steve, okay, if you don't exploit, what's a recommended time to wait and see? You said 6 weeks, but I mean, what if it needs more time? I mean, how do you know what's the correct time?
It's the standard unit of orthopaedic time, isn't it? I mean, I don't do a huge amount of these. My upper limb guys guide me a lot on these. You know, they may go a bit early, they may go acutely. I've got no consensus with them. You know, I mean, it's a difficult one, because you're either saying that the initial examination was wrong, but I think it's a really valid point. There's been an intervention, and the neurovascular status has changed.
It changed, yeah.
So yeah, are we almost mandated to it? And perhaps that's the most important point, is that it was fine. We did something, now it's not. So, yeah, I guess maybe we should think about that as the important bit.
And ironically, we all know that a radial nerve fallout that is picked up initially with a humeral fracture actually does recover in 85 to 90% of the time. But this is a slightly different scenario, because it was initially charted as intact.
It's interesting what you say, because that's what the standard sort of thing, it recovers 90% of the time. But if you look at the other side of the coin, insurance claims about very large numbers of patients with radial nerve palsies. The recovery rate's not 90%. They state the recovery rate's about 60%. So there's a bit of a mismatch there from people saying it's weak. So maybe there's no consensus. There's still a lot of debate. We don't actually know which ones we should for sure. I think when it does change, definitely you should explore.
Okay, two more. So Cynthia, and then table 6.
Yeah, I agree with you that if it does actually change, you should actually go do something about it. And the fact that you said it was a dense, there's a difference. So there's subtleties that you look at clinically, that if they came with a neurological fallout, but you look at the snuff box, it's a neuropraxia, you can tell that it's actually maybe a type 1 or 2 that will recover. But there are those who present with a dense, meaning even sensation might actually not be there at the beginning. So those ones, you know that they're probably entrapped. So then I would actually go in. Once you say the word dense, that's a significant injury to the nerve.
Can I ask how people... Sorry, you got a question? Yeah.
Recovery. Are you talking of similar site lesions or lumping the whole radial nerve as a whole?
If I understand correctly, it's more proximal humeral fractures with radial nerve fallout. The distal ones, like the Holstein-Lewis, I mean, that's plain straightforward. I mean, you have to go in and fix those to get the radial nerve out. Interestingly enough, when I was a registrar eons ago, I actually had follow-up on, I did a follow-up on radial nerve fallout in proximal humerus fractures. And I went to explore quite a few of them. I think I followed up about 30, and 10 of them I actually started exploring at about, I think it was about 10 to 12 weeks. And ironically, a lot of them were encapsulated in the callus. So they would never have recovered anyway, because they were sort of stuck there.
Yeah. Okay.
Okay, I think we're time up.
Thank you.
Okay, thank you very much. That's awesome. I don't think we've ever got through so many cases in a humeral session. Thank you. Cool. So I've got non-union. Those who don't know me, this is where I live. This is Bristol. That's my hospital. The Children's Hospital is the pretty modern building on the left. The plastic-coated, slightly ugly building in the middle is where I work, and you can just see the horrible concrete prison-looking building. That's what it looks like underneath the plastic. That's where I work. Bristol's quite a nice place. Definitely nowhere near as nice as Cape Town. We've got a nice river and a harbour and a bridge. If you want to find us, you come out of Heathrow, turn left, drive for 2 hours. You're in Bristol. It's pretty straightforward. So yeah, we're missing a lot of what you have here, but we do have the Alps pretty much on our doorstep, 2-hour flight. So that's where I spend a lot of my time because there's not a huge amount else to do. So I thought what I'd do is I'd actually bring something that highlights how bad we are at managing things that we don't see very often. So this is probably something you guys are all looking at going, yep, see plenty of these. This is something in the UK that we look at and go, what the hell do we do with this? Because we don't see them. So this is a nice chap. He's 28 years old. He and his brother decided they were going to take a sabbatical from their nice, well-paid office jobs. And what they were going to do with their sabbatical was they were going to fly down to Brazil and start dealing drugs. Because not like the locals that have a problem with that, is it? So they just shot him a little bit. Just as a bit of a warning. So he had this done in Brazil. So he had it fixed in a primary closure and then decided on maybe come back to his nice, safe office job and came back to Bristol. So any thoughts, comments? Good job, bad job? Run with it, just let him get on with life? Anyone? He's about 5 months, maybe 4 or 5 months. Yep.
I think the fixation is inadequate. Sorry, the fixation is inadequate. Certainly the 2 screws proximally is not enough. The lever arm is just too big on that fracture, and the distal screws, I think they've put locking screws there. I mean, I think a lateral would have shown us better. But this is in the process of failing.
Okay, is it far enough failing that you're going to do something about it, or are you going to let it fail properly?
I'm going to do
but
something.
I mean, I asked that, Rick, because I haven't figured that one out yet. You know, when is it so bad I have to do it acutely, or when it's not quite bad enough that I can run with it for a bit? So I asked that very genuinely. I mean, would you give it a chance even though it's not good?
I think there is callus on the medial side. As long as there's no infection or anything, there's not a lot of halos around the proximal screws. This could be acting as an internal kind of Samiento brace. And you could leave it and run with it and see what happens.
Okay, yeah. Okay, anybody?
Steve?
I wanted to ask, when he came to you, what was his complaint?
He'd just come back to the country and he knew he'd had an injury and his GP advised him he should come and be seen in the local orthopaedic unit.
I'll just follow him up, though improper fixation, but I'll just follow him up and see what happens.
Okay.
Send him back to Brazil, maybe.
Yeah, he's not too keen on going back to Brazil. Yeah. Okay, anybody going to jump at this acutely, or are we all just going to run with this and see where we go? Yeah.
It's not straightforward since what you expose now. However, apart from being the immobilization or the fixation insufficient, remember the deltoid is attached right there, and whenever he abducts, he's going to be moving, contributing to the motion in that area. So there's quite a large area of comminution. There's no contact, and we all know that the humerus likes contact between the fragments. So I will consider revise that.
Okay, so you go acutely?
After discussing with the patient.
Okay. And what are you going to revise it to?
Proper fixation with the plate.
Okay, so
just
same
remove
approach?
that one, shorten in there probably, maybe bone graft, reduce nicely, it's in varus for the look of it, and then at least 3 screws proximal, 3 distal.
Okay, so 3 and 3, acute shortening, bone graft.
At least, yeah, and bone graft.
Single plate?
A single plate, yeah.
Yeah,
probably.
great. Thoughts? You're going to sit tight. Okay. Okay.
Steve, the patient's not complaining, right? So
He's got a little bit of a niggle, but nothing. Yeah, you know, he's managing.
because if you go in now and he gets infected and all of that, non-united, then it's your fault.
Yeah, you become the villain, right? Yeah. Oops. Okay, so he muddles on for a little bit, and then maybe 2 months later he comes back with a little bit more pain. It was almost predictable, right? Yeah. Okay, so the person who saw him did a CT.
No, I wanted to ask now. He comes back to you, say, 3 months later.
It was about 2 months after his first X-ray. He's come back with.
And then you see that.
He's come back with this one, with some increased pain.
Yeah, then if there's increased pain, then it means something needs to be done.
Okay, so what's your plan? Anybody want a CT? Assuming you can have it, does anyone think it adds anything? No? No. Yeah. So, yeah. So this was referred to one of my upper limb colleagues who wanted a CT. So maybe he had a holiday coming up and he was hoping he could escape before the CT got done. I don't know.
I'll nail it.
Nail it?
Yeah.
With acute shortening?
Yes, yeah, with acute shortening, just remove that plate and not interfere too much with that fracture site and just rim it properly and nail it.
Yeah. Okay. Anybody like that idea or dislike that idea? There's a nod of the head. Yeah. Is there any shaking of the head? Anybody who doesn't like that idea? Because that's way more fun. You don't like it? Okay. Tell us why. We've got the microphone, please. Thanks.
Don't like the nailing idea. That's
Okay. Tell us why.
Because you have to. It's a non-union. The metals fail. You have to remove the whole plate. Then you're right there. You have to debride it, shorten it, put a new plate. Simple.
Okay. Single plate, two plates?
Single plate.
Okay. Graft?
Yes.
Yeah. Always?
In this case.
Yeah?
Yeah.
Okay.
Just to add to that, please.
Yeah.
To deal with that screw that is broken there will be a bit of a challenge there. But the nail is a possibility if you can just bypass it. However, you're going to cut him this much to remove all of that, and you're right there. Why not revise the plate? My previous point. But I guess there are two ways to kill a cat, at least.
Okay. And if you're nailing it, are you just a nail? Are you compression nailing? Are you nailing with a small augment plate?
Yeah, if I've already opened it, removing the plate, so with this difficult removal, I always have a high-speed pair, just pair the bone, remove the screw, and with a bit of shortening and nailing, I think if I'm opening to proximal there to remove that plate, I mean, it's just another small incision to insert the nail.
Okay. Anybody worried about infection? Anybody thinking about staging it, whether you're going nail or plate? Would anyone stage it, or everyone just do it as a one stage? Everybody one stage? Yeah.
The infection is a big possibility, but I mean, take samples, still do a single stage.
Okay, so do as one, but just intraoperative sampling. Yeah. Okay. Okay. So you had a CT. That was a CT. Not sure what it added, but anyway, apart from some time. And then we had the blessing of COVID that came along. So he wasn't seen for some time. And then he came back. So he's now 3 years from injury. His distal screws are starting to go the way of his proximal screws. And he's got pain. He's kind of almost got a second elbow starting to happen now. So any changes on what we discussed last time? Any new ideas, changes in strategy?
It obviously now just becomes more complicated. More broken screws, higher possibility of infection.
Yeah.
yeah, you will need to go in and revise everything. I would definitely shorten it, but I would take specimens because there is a high possibility of infection. But still, we do know that a stable infection, stable non-union is much better. Or let's put it this way: a fracture that is fixated and is stable is much better than an unstable thing. And if it's infected, so I would definitely try and revise that, shorten it. If it looks septic, I wouldn't bone graft it.
You wouldn't?
No.
Okay.
If it's septic, I wouldn't.
Oh,
It's just going to augment.
So you're saying an infected union is better than an infected non-union?
Yeah, it came out quite weird.
Oh, yeah.
It's part of my verbal diarrhea.
Yeah. So in infection, better with stability than instability. Yeah.
But I do have
Yeah,
a question. Is there any sense of doing a bone scan on this patient?
Yeah, it's a great question. So who would find that useful? Either in bone scans or PET CT or something? Is that going to add anything? And what are you looking for?
Well, if you have white cell guided bone scan, you can definitely find out if there's an infection even before you start, which makes your approach a bit more problem orientated. Like I said, if I know there's an infection, I would like to know what organism it is, so I'm going to take a lot of specimens, and I wouldn't do a bone graft. I would go in and plate it to get it stable, but I wouldn't do a bone graft. So yeah, I would that's why I'm asking, because I would consider doing a bone scan on a patient like this.
Anybody would think about a biopsy prior to any intervention? Anybody think about a guided biopsy? Or do we think that's possibly not particular? You'd think about it? Okay. Got one there. Anybody doing those, not routinely, but select cases? Think they're useful? Mm-hmm. No, sort of CRP's, sort of 15-ish, thereabouts. What counts normally is he's systemically well. The wound is looking okay. So he sees the same upper limb surgeon who gets another CT. Hoping another holiday was going to come along, but it didn't. So any big changes?
CTs, Steve?
It was the usual thing. We're unable to comment due to metal artifacts.
Correlate clinically.
The radiologist's favorite. Correlate clinically, right? Yeah. Yeah. I love it. All around the world, and we all get the same reports, right? Probably done from home in his lounge and his socks, right? Yeah. Okay. Anybody got any worries? Anybody think it's good news there or bad news there? Or anybody just looks at it and goes, I have no idea what it's telling me? Yeah.
Well, the one thing it helps you with is to see the severe obliteration of the canal. So you know that you really have to prep for those that want to nail. It sort of guides you where you're going to have problems.
Yeah. So I hadn't met this yet, but when I got involved with this and looking back on it, the thing that worried me with this was comparing to the previous CT is that there is no change. So my big worry with this is actually, is this just a big piece of dead bone in there? So perhaps the detail, not that important, but actually the lack of change was maybe something that flagged up. So he decided he was going to go in and do something about it. So he went in, put a couple of cement rods in, started debriding it, and then realized that quite a lot of it was dead. That sort of brittle that you don't really, you can snap off with a nibbler very easily with no effort. So he started nibbling back, and then got a bit nervous about how much bone he was taking. So plated it, and left it with that. There we go, 3/5 plate. Fantastic. We all know that's going to work, right? That's exactly my face when he came to me with this case. I was sitting there going... Okay, so what do we think? I mean, this is part of a staged strategy. So this was step one. He was going to come back to do something after this. And the plan was get his samples back. He'd put antibiotic rods inside. He'd got stability, so he claimed. and he was going to come back with a plan to revise this to more definitive fixation once he's got his specimens. This was a two-stage. So anybody like that as a two-stage? Would we? I mean, I've got the feeling everybody's thinking more would have just done a one-stage. Yeah. Who would have shortened it a bit more, improved the contact? Yeah. Okay. And anybody adding a second plate? So I mean, go a bigger plate than that, but add a second smaller plate in resistant non-unions. I think these transverse fractures with resistant non-unions get a bit worried. Grafting. Show of hands. Who's grafting this one? Grafting? Well, you don't know because you're doing it as a one-stage. Okay, so who's grafting doing it as a one-stage? Show of hands. Okay, and who's not grafting it if they're doing it as a one-stage? Okay, so about half and half. Okay. So 12 days post-op, he comes back. You know.
Just a quick one, Steve. So 2 issues here. It's both a mechanical stability issue and a biology issue.
Yeah. Yeah, so we've got an unknown infection,
Yeah.
possible yes or no. We've got a biological issue and we've got a mechanical issue as well.
Yeah. So then doing a one stage without grafting, be thinking that down to good bleeding bone, it should unite after.
Yeah, so for me, I think the alarm bells for me were ringing of he's telling me that this is dead.
Yeah.
So for me, he's not addressed biology with this.
Yeah.
So for me, I think if I'm not a big fan of grafting. I think you're putting in something that's dead into a cavity that's dead and possibly infected. And I think if you can get back to good viable bleeding bone, then if you optimize the mechanics and the fixation, you're almost going back to square one, as long as you've got good soft tissue envelope. So I'm a little bit cautious with grafting acutely.
Bone substitute with antibiotics?
I might think about antibiotic delivery, something absorbable, something along the lines of stimulant maybe, in the canal. Just make some beads and souse it with that perhaps. Anybody throwing vancomycin powder around in these query infections? I know there's a lot of talk about throwing vanc powder into wounds. Is anybody any experience? I'm not, but Hitesh? Any particular situations that you'd always do it, or?
High-risk cases that concern about infection, just vancomycin powder into the wound. That's something.
So, prophylactic. Okay. Yeah, of course.
So, let me just get it again. This was part of one of the stages or something else?
Yes. So this was stage one of a plan to go back and refix once he got his cultures back.
Knowing the compliance of this patient, having failed and having gone for drugs and this and that, why couldn't we immobilize him with something else to support that? Because it was destined to happen. That plate is doing absolutely nothing.
His compliance is good.
Huh?
Yeah, since he came back from Brazil, he comes to all his appointments.
Now he's clean, yeah.
He's back working in the office.
But what I'm saying, now the gaps still remain in there, the screw fixation is not adequate, so it was destined to happen, something else to happen. Yeah. So what about putting some splint tissue, something else to try to help him for another 2-3 weeks until he comes?
Yeah, so I think he was in the brace when it fell to bits. Okay, so where are we going now? So this is now about 3.5 years from his gunshot. He's defeated the mass ranks of British orthopaedic surgery. Doesn't take much.
I will send this case to Cynthia.
Was there any infection, Steve?
Sorry?
Was there any infection?
Yeah, so it's interesting. When he went back to do this, he took biopsies and everything came back negative on enrichment culture. He didn't take any histology, though, which was always in the back of my mind. Okay, so where are we going now? So he's already said this bone, he has concerns. He said he wanted to take more, but he was too frightened to. This has now failed, so where do we go now?
I would consider, as long as there's no infection, and I'm pretty sure there's no infection, I would consider going back there and trimming back the bone to bleeding bone. Try and get either an oblique osteotomy kind of situation. And I would plate it. I would go more lateral with my plate. A long plate with 10 cortices above and below, and hopefully a compression screw across that oblique segment. But I would also add a short medial plate, or plate it.
Okay, so you're going to create...
My only consideration, if I'm thinking about infection, possibly since he's put the antibiotic already up and down, is to also consider putting some antibiotic beads, absorbable, into the canal. It's already there for me. Consider doing that if I think there might be any.
Yeah, and I think you don't lose anything. We're not going to have to go back and take them out, so I agree. I like the idea of just increasing your contact area with an oblique plane. Would you put an interfrag screw across that? Yeah, and go for a complete, real absolute stability construct? Yeah, I think that's good. Okay, so we've got shortening as much as it needs, oblique plane osteotomy, lag, 2 plates, graft? No. Okay, and no graft? Yep.
I would say I'll revisit the thinking of moving everything, the implants.
You go with the nail? Yeah.
Go with the nail, yes. Because you said the necrotic tissue or bone.
No, so there's still dead bone in there. So he lost his nerve. He was debriding, and he was taking away a lot of bone, and he just said, there's still dead bone, but I'm out now. He was nervous about what he was going to do if he kept on going.
So how much of dead bone do you have? Because I think we can, like you say, you can...
Yeah, well, that's the fun bit. So we don't know. So he's probably taken at least 2 to 3, and then he said everything was still dead. There was no bleeding. But at that stage, he got nervous about where he was going to stop. So he bailed out at that stage. So we don't know how much more of this is dead. It's fun, isn't it? Okay, yep.
Well, I concur with that. Debride, remove everything, and carefully rim that humerus and throw a nail down. That would be my choice.
Yeah. Okay. Pax, any thoughts? I know you're loving this one. I've never seen you giggle so much.
I'm laughing because probably I'm saying to the guys on the table, probably the Brazilians stripped all the periosteum there. So this is why probably the bone is dead.
Yeah.
Yes, yeah. So I dealt with this. It was a radiation-induced pathological fracture with the dead bone from top to the bottom. Yeah, so if it's dead bone, then you have to take it. I think, but you need to go with someone who's more like experienced in assessing the viability of the bone. So now, if I come across it like this, I wouldn't nail it now. So I would take everything out, debride the bone as much as I can, and then do a cement spacer, and then think about the second reconstruction procedure.
Okay, so debride, resect, preserve length, cement spacer,
yes, yeah.
and how are you going to stabilize in the interim?
Yeah, for stability, then usually I'm very thorough at my debridement. I don't worry about my infection after I've done my debridement, so I will go with like a large fragment plate to stabilize the humerus.
Okay, so same, you had a big extensile anterolateral approach, so
yes.
back in through there.
Yes, yeah.
Large fragment bridging plate.
Yes, yeah.
And a cement block. Okay. Anybody else? Yep.
Why not go completely extreme?
We love that. That's what this meeting's all about.
Go in, do a complete debridement of all the dead bone, and then ask our favorite colleagues, the plastic surgeons, to do a vascularized fibula graft.
Nice.
And put it in there, and then just a very strong plate from top to bottom.
Yeah.
And squeeze it in there.
Yeah.
because then you've got vascularized graft. You don't lose stomach length, and you might have something viable.
Yeah.
But that's extreme.
Yeah, I think it's a brilliant idea. Yeah. Does anyone have a lot of experience with free vascular fibulas? Fax?
Non-vascular fibula.
Non-vascular?
Non-vascular, yes.
Okay.
I've got a case series of 6 cases,
Yep.
which all united. Non-vascular harvested on the autograft.
Okay. And you
Yes.
just take a single strut, or you split it, almost double barrel it?
No, I don't split it. I just go shove it in the metaphyseal areas of
So
both
use it like
sides.
an intramedullary rod?
Yes.
And then bridge plate
and
across?
then large plate.
Yeah. Single plate or 2 plates?
Single plate.
Single plate?
Yes.
Okay. With screws through the graft?
Yes.
Where it's sitting
Yeah.
intramedullary?
Yes,
Yeah.
yeah.
Okay. And what sort of time are you seeing union? And are you talking just
so it's
union?
young patients. Usually these gunshots, they get referred to me.
Yeah.
With the sepsis and all of that. So it's young patients around about between 25 and 35.
Yeah. But in terms of time to union?
Or time to
Yeah.
union, about 6 to 9 months.
Okay.
Yes, yeah.
Yeah. And do you restrict them at all?
Sorry?
Do you restrict their movement or loading through the limb after you've done those?
Yes, I restrict loading, just basic function of the limb is permitted, but I usually restrict heavy lifting and all of that.
Yeah.
Yeah.
Okay. Right. And have you been involved with many of the vascular fibulas?
Ironically, no. I do exactly the same. We've harvested orthofibula and then bayonet it into the medullary canal.
Yeah.
We also do it sometimes for very comminuted proximal humerus fracture. Use it as a strut.
Yes, just to splint up the head fragment.
Yeah,
Yeah.
yeah,
Yeah.
I don't know if it really makes a difference. It just makes me feel better.
Yeah.
For
Do you
the
drop it
proximal.
down the canal?
Yes.
Yeah.
Yeah.
So I think
I wouldn't want to go do a shoulder replacement after that. But
yeah, yeah. So I think I've still got a little bit of memory. So I think the last time we were here in 2019, Andy Barrow had a really nice tip for those. Is that instead of going all the way down the canal, he just takes a much shorter one and sticks it at an angle, so it's sort of butting on the lateral cortex, and then stuck up into the head, just to prevent that varus collapse, rather than going down, which I think is a really nice tip. So anyway, so he made the fatal mistake of referring it to me and saying, I'm a bit worried about this, can you come and do it with me? And I went, okay. Yeah, and most of that humeral diaphysis was just, I mean, I didn't really need any instruments to take it out. I snapped it off with my fingers. So that's resected back to viable bleeding bone, both ends, with a cement block, took a load of new specimens, reamed the canal. I think Cynthia's point about where the canals were clogged, exactly right. So we just used a very small, so off the pediatric femoral nailing set, has a really nice 6mm powered reamer, which is really nice to go sort of 6, 6, 5, 7, which is really nice for doing humeral cases to get through. Okay. Thoughts? Crazy? Shortened him down a little bit, but he's quite happy because the first time in a couple of years he's actually only got one elbow. He's got this tiny little lump of a biceps, which, look, it moves. Okay, so where next? Go for it.
My question is, if when you were doing the debridement, you find that more of the distal shaft is involved, that you're not able to put in a nail in there, what would you have done?
Then I'd probably change it out to maybe a Lazarov or plate instead. So I think with this one I had everything available. And it was going to be depending on how far we had to go. And I think that's the difficulty going at it second time. I know it's dead, but I don't know how much of it's dead. So I think it's a really good point. You've got to have something to cover all the eventualities. Okay, so thoughts about reconstructing humeral defect? So I had exactly the same thought as you. So I'm very lucky. In our neighbouring hospital, we've got a fantastic trauma plastics unit. So all they do in their state work is trauma reconstruction, nothing else. They love this kind of thing. So I threw it to them and just said, what do you think? And they were all over it. They were like, yeah, we can do that, we can do that. Just get a CT angio. So we did the CT angio, which unsurprisingly after a gunshot didn't look anything like anything that you'd want. So they were looking at it thinking this is going to have to be plumbed into axillary or a distal vein loop and potentially quite complex. They said doable, but potentially with risk. So any other thoughts for humeral defects? Cultures have come back negative again from this, and histology is negative again. Sorry, first time. Cynthia?
Yes, the fibula, vascularized fibula works very well, and also the femoral medial condyle for smaller ones.
Mm-hmm.
We can then connect it closer to the elbow for the non-unions that are sort of closer to the elbow.
Yeah.
Distal humerus, yeah.
Yeah,
that
so
works
yeah,
well as
medial
well.
femoral condyle is a nice, big sort of
Yeah.
cancellous block, heals really nicely.
100%.
Okay, but for this one, I mean, this is about 12, maybe 12 centimeter defects, slightly oblique both ends.
Good, what you did is good.
Yeah, but where do we go next?
Nothing.
Yeah, nothing?
Nothing.
Just leave him with a nail and cement.
Yeah.
I love this idea. It's so good. Has anybody done that? Anybody else done it? Yeah? Yeah, and how many of them have come back unhappy?
Maybe out of the 7 I've done, maybe 1 or 2.
Yeah, so I've done 3 or 4
well, yeah.
in these patients, and they're the kind of the chronic infected, unstable, life, absolute misery. And then you go, okay, just come back and we'll talk about reconstructing the defect. And they go, no, I'm not in pain, I'm not infected for the first time in years, leave me alone. They don't want to come back, but he wants something doing. Damn. I was hoping he wasn't, but he wants something doing. So any other options for diaphyseal defect in the humerus? So we talked about vascularized fibula. We talked about non-vascular fibula. You'd still do similar.
But one of my cancer patients I treated like this.
Yeah.
Yeah. So just one patient I've treated like this. The rest non-vascularized fibula.
Yeah. Okay. And any worries about getting a plate all the way across that with
Yes.
stability?
Yes. Yeah.
Yeah.
Always plate. I've never thought about nailing it, but yeah, I'll consider that as well.
Great. There is. Yeah, so you can use the straight precise. So the sort of mini one, I think starts at about 150, I think, which will give you a 5 centimeter stroke on that one. What are you thinking? I like it already. So doing plate assisted transport. Yeah, so put a long plate, precise, and go. Yeah, it's nice. So you're probably going to have to do two, 3 nail exchanges. Yeah. Anybody done many of those? Plate-assisted transports with the lengthening nails? Yeah, I've done a couple. Selected cases. They've been all right. They've not been, I don't think they're as easy as they're made out to be. I think the technical aspect's quite difficult. Mascale, anyone? In the humerus? No? Works 100% of the time, right? Just like mascale everywhere.
Does muscular have a length cutoff point?
Well, not if you talk to the people who do lots of it. They just go, no, it works 100% every time. No revisions. Whatever size defect.
The initial authors always say this,
Yeah.
no problem. I suppose if you can lengthen it with a humeral nail, you can start lengthening it with rings as well.
Yeah. So transport it, yeah.
Yeah.
Possible, yeah. Anybody got experience with masculine defects this size? No? Nobody? Jitesh, thoughts? No? Think it'd be a bad idea? Yeah, I love it. Everybody's going, yeah, it's amazing. You sit here and ask that question in Europe, everyone goes, masculine's fine, yeah, it'll be done in 3 months. Yeah, it's fine, next. Okay. So we did one of these. I was just a little bit worried about mascule. Plate assisted, I was thinking it's going to be 3 cycles with precises, probably difficult in terms of real estate to fit that in. So this is a 3D printed absorbable cage, which I think in the upper limb is actually pretty good. So we reared the other femur to get the graft, and then essentially it hinges in 2 planes, custom print to the defect. So that's the nail coming out in the membrane, filled with autograft, which I mixed with chips just to give it a little bit better consistency. and it's pre-printed to accept the nail down the middle of it. So essentially, it's kind of like a Mascale Turbo. I like that it's osteoconductive, it's osteoinductive, it kind of optimizes graft density. I think it'll only work around a nail. I don't think it'll work with plates or for arthrodesis. And it's not really a huge intervention. So he's pretty happy. I'm not sure if this will work. So I saw him last week. He's about 3 weeks post-op. His elbow's stiff as hell from 3.5 years of immobility. But his shoulder range is actually pretty good.
Brilliant. That was fantastic.
So we'll see where he ends up. But yeah, I mean, I think big bone defects are difficult. I'm not a big believer that Mascale works in a defect this size. And I think, for us, we don't see these. And I think, yes, you have to think outside the box. I think you've got to look at this and go, it's a vascularized fibula. Technically, that wasn't possible, so we've had to go in a slightly different direction. So I'll report back. I think there's been about 170 done globally. We've done 12 in the UK now. Longest follow-up I've got is about 18 months on a tibial defect, and they seem to be doing pretty well. We can load them, we can walk on them with nails, but we'll keep you posted. Cool. Okay. Well, I think we're only 5 minutes late. That's been a great session. Thank you very much, everybody. Oh, sorry. One more. Yeah.
We had a similar patient with a gunshot as well, presented after 12 years with a similar defect that was nailed, and the nail got loose. Unfortunately, it was an older patient. We put a titanium, custom-made titanium
with the
cage.
truss.
Yeah.
Ah, fantastic. Yeah.
Still waiting. She's about 2 years down the line. I mean, she's got some bony growth on either end, but she hasn't filled up fully.
Yeah.
Very happy.
Yeah, and I think they work really well. I think for us to get hold of them in the UK, the cost is absolutely prohibitive. I know I've spoken to Nando about them quite a lot, so I think he's done quite a few, and talking to him, he's got similar experience to you, that you get a partial ingrowth or overgrowth, but you get patches where it doesn't. But actually, functionally, they do really, really well, and he's got pretty good long-term follow-up on them, so I think it's a really nice solution. Okay, so it's coffee break now. We're due to start again at 4:15, if that's okay. So thanks again, and we'll see you shortly.
We'll figure it out.
Aortic vein.
Are you serious? In the aortic vein.
You know the aortic vein. He knows the words, but he didn't put them together very well.
Good vein and he's good aorta.
Yeah, together. Sounds serious. Sounds serious. Sounds serious.
The way you point.
Sounds deadly. I'd rather the aortic artery rather than the aortic vein. No one knows how to repair the aortic vein.
see it, yeah? Start. Start it. You can see it, yeah? Start. Start it. Okay, so this is the reduction.
Do you also use that line? Yeah, the look.
Right. Okay, hope you're all refreshed. This is a little break from the routine of cases. I think Andy sort of said there's a bit of a trend of for the overseas guy talking something completely unrelated to anything about fractures. So this is something that's kind of been quite big in the UK, is strikes. Have you guys experienced this sort of industrial action in medicine yet, or yeah? Yeah? Okay, was it a complete shit show like it is in the UK? Yeah, okay, so this is kind of the real story. This was really a war that's been fought mainly in the press, which is very much either right-wing, left-wing, or somewhere in the middle, depending on which paper you buy, and completely overwhelmed social media in the UK for about the last 18 months. So this is actually what it was really like. So this is kind of what triggered it all, was this sort of concept of pay erosion. So this was amongst the whole of the NHS workforce, so the doctors, nurses, radiographers, physios, consultants. This was the perception of drop in pay. So the RPI was used by the BMA, which was a 26% erosion, and the government said 16%. So the only difference between these two metrics, which are calculated on an average basket of groceries, is that the RPI assumes that you actually own a house to keep those groceries in and live in, which kind of pretty much everyone does. So the reality is it's the RPI. And it's really just been a gradual thing, really. So this has been sort of a sequence of pay erosion. And it's interesting that all this was triggered by everybody apart from the consultants who've actually had the worst pay drop across the years. So that was kind of the main reason. There's a big problem with loss of workforce overseas, just in terms of working conditions, salaries, hours that you have to deal with. Debts from training. So the average newly qualified doctor is running about 180 to 200,000 pounds of debt in terms of university fees, training costs. So it's hugely expensive. A lot of burnout, mental health, the post-COVID hangover, waiting lists growing. There's just no investment under the Conservative government. Our hospitals are falling apart. They're not big enough. We don't have enough beds. We don't have enough operating theatres. We're diagnosing more patients, treating older, sicker patients. And so certainly my hospital has had no new build for 25 years. And the number of patients we're treating, so the whole system has fallen apart. And then we have this lovely thing at the bottom, the DDRB. So these are the people who are apparently an independent committee who make a recommendation to the government about what pay rise we should get. That's the committee, all of which are government employees. None of them are anything to do with the medical profession. So they sit there and then they speak to the Treasury who go, the economy's screwed, inflation's through the roof, this is all we can afford. So it's very independent and fair, as I'm sure you'll appreciate. So these are the villains of the piece on both sides. So our friend Rishi in the top left, possibly the stupidest man, but very eloquent. The guy beneath him, Steve Barclay, who's the Secretary for Health. So they're kind of in the blue corner. In the red corner, that's Vivek Trivedi and Rob Lawrenson. So they are the junior doctors' BMA representatives. So Vivek's an anaesthetist, Rob's a GP trainee, who looks uncannily like Where's Wally? Who knows? So anyway, so they're now known as Vivek and Wally. So this is Rishi's fantastic plan. So this is what he promised on the left, which generally he's failed on pretty much everything that he promised. So isn't that strange for a politician to promise and not deliver? Very odd. So this is all kind of stuff that he's failed just prior to these strikes beginning. So, you know, it was pretty much a disaster before the industrial action started. So these are the unions that were represented. So there's the BMA, Hospital Consultants and Specialists, Royal College of Nursing, Unison, GMB, Unite, and the radiographers. So huge range of unions involved with this. And it was quite a hit for the government that so many sides were coming out to fight against them. It was a bit of an ethical thing and a bit of a moral thing for people. Just the hit it was going to have on patient, staff, finances, you know, cost of cover, the moral injury, staff losing income from going on strike. You know, the public were generally very supportive. The question was, how long was that going to last? And how are we going to cope with all the rescheduled appointments, and were the health outcomes going to be worse? So a lot of us kind of struggled with the ethics of it. I think everybody was agreed that something had to be done, but everybody was kind of quite conscious of the potential hit on our patients and the long-term impact of public opinion, where that would end up. So they decided they were going to strike. First one was in March 2023. They were going for full pay restoration. And it was pretty overwhelming, really. So they had a 77% turnout in the vote. And of those who voted, 98% voted to strike. So it was pretty unanimous across the junior staff. They'd had enough and they were all prepared to strike. And off they went, worth more than £14 an hour. And what a great gag this was. And I don't know whether they paid them. So Pret is a very famous coffee chain. So the BMA's first little advert was, junior doctors can earn more as a barista per hour than they can as a doctor. What was the difference? Anyone know? Junior doctor got paid £14.09 an hour. Do you know how much Pret paid a barista? £14.10. That's fine. These fine margins are important, right? But yeah, so anyway, on that 1 penny difference, this whole advertising campaign was launched about I'll be better paid as a barista by that huge 1 penny an hour. Wow, what are you going to do with that? So anyway, it carried on. All over the press, pretty much every day, the TV would be covering this. It would be in the papers. So thus far, there have been 9 strikes over a 10-month period. They've been out for 35 days in total. Shortest strike was 2 days. The longest one was 6 days, which was a real tough one to manage. So obviously, if the juniors aren't there, we have to be there. And it's kind of a mixed bag of responses. So essentially, all we had to do was figure out how we were going to cover service. So we'd have whoever was on call normally, somebody would do trauma in the morning, somebody in the afternoon, somebody would be on each of our orthopaedic wards, somebody on the outlying patients, somebody covering the night, two people covering the day, people on weekends, people trying to run some kind of emergency fracture clinic. And we tried to sort of juggle it around, really, between 12 of us, which sounds awful, but actually it was all right. You know, we kind of coped, and suddenly, oh, wow, I haven't seen you in about 3 months. And suddenly we'd be doing a trauma list together. It's like, wow, this is fun. So this is what changed. So my hospital is the red star in the middle, smack in the middle of Bristol. We have an elective centre, which is Southmead, which is also our level 1 trauma centre in the north. and we have our little local community hospital, which is our elective day case unit, and we're normally spread across those 3 sites. But elective surgery gets canned during the strike. Everybody comes back to their base hospital. And what we noticed that the waiting times in the emergency department, big crisis over 4-hour waits, and suddenly it didn't happen because we just walk down and go, no, send, because we can. And it was, okay. Admission numbers went because we could just discharge people at the point of arrival. Discharges went through the roof. Suddenly there were empty beds all over the hospital. I mean, admittedly, no elective work coming through, but suddenly we've got beds everywhere. And the investigations requested fell as well. Go figure, yeah. So suddenly, all the managers are going, wow, all these targets that we've been failing to hit for years with those bloody junior doctors. Clearly, we just need to fill the hospital with consultants. This is brilliant. And we're like, you do realize you're getting no elective work at all. Ah, yeah. Do you have managers like that? Is that another global phenomenon? Yeah, they just understand nothing, right? Okay, good. So we kind of broke this down into the good, the bad, and the ugly. So what was good? Well, basically operating with your mates. You know, how much fun is that? You know, the person on the other side of the table can do the operation as well. It's just the nicest feeling. So we started doing all these crazy cases that we'd had hanging around because suddenly they weren't at the elective centre or the day case centre. So lots of dual consultant operating. We got way more efficient theatre use. It was like CPD. You know, I was doing operations with colleagues around the elbow that I've not been there in years. It was great. It was lovely to see something new. Lots more MDT style working. We started arranging social things. You know, wow, we actually all got together outside of work and realized we didn't all hate each other. Actually, it's not bad. But actually what we did understood is what is bad for our juniors. You know, that the way the system has become so pre-planned and orchestrated, all the guff and the waffle and the admin and the unnecessary paperwork was suddenly there for us to do. And we were sitting there going, this is awful, we've got to change it. Bleep rage. Anyone ever had bleep rage? Oh my God. 2.5 hours I was on call as the SHO with a bleep. Oh, 2.5 hours before it hit the wall from the far side of the room. And it's really irritating, isn't it? You know, I can't do that at my age, I hated it. So we realized how difficult their job had become. Doing resident on-calls, covering patients on the ward, really didn't enjoy doing that. Trying to remember acute medicine and how it applies to patients over the age of 85, it was interesting. Yeah, we had to cancel our clinics and our elective work, so we're already in the backlog of COVID, so that was a big hit. Oops. Yeah, so this was the thing that we have changed. So if you come into my hospital with a hip fracture, or even a suspected hip fracture, or a femoral fracture, or a periprosthetic fracture, or now pretty much anything in the lower limb in the elderly, you have to complete one of these booklets, which is 47 pages long. So we had no idea it got this big. So our orthogeriatricians have taken this thing, which was about 8 pages when we designed it. It's now 47 pages long, and it's full of all this absolute guff. And we realized our juniors had taken about over an hour to admit one of these patients purely on paperwork. So what we came out of it, and we said, okay, well, we'll do the orthopaedic bits, and then when orthogeries see them the next morning, you can do all your data mining, fragility scores, dementia scores, all that sort of stuff. We're not doing them anymore. So suddenly our juniors came back from the strike going, guys, this is brilliant, thanks so much. Winner. And then there was the ugly. So it started getting further down the road with the strikes, a little bit more kind of scorekeeping over cover. No, well, I've done 3 nights. No, I've done 2 weekends. It got a little bit chippy. Our clinical lead didn't perhaps play things too well. Bit of verbal abuse and threats towards the juniors. That ended up with the legal team involved and was all quite unpleasant. But I think he was just quite stressed trying to organise strike rotas. Perhaps didn't go about things in the right way. Battles with the trust over pay or time in lieu for all the sessions we were covering. People cherry picking, just going, no, I'm not doing wards. I'm too old, I'm not doing wards. I'm just doing that. I'm not doing any on-call. So that was a bit awkward. And the interesting one was threats to annual leave and study leave. So, you've had a family holiday booked for 6 months, and then suddenly the hospital are going, yeah, we're going to have to cancel that. So that all got a bit unpleasant with lawyers involved before we had to get them to back off from that one. So this was the rate card, which was interesting. So this is what the BMA came out with and said, basically, if you're covering a junior doctor overnight, per hour, they have to pay you £269. Wow. How to get consultants to come and cover night shifts, right? Wow. It's like, okay, so I do a 12-hour night shift at 270 quid an hour. I'm in. I'll do it. But the problem is most of that will get taken away in tax and pension and national insurance, and you'll see probably about 35% of that. So the best bit is the bottom one. So this is, they give you time back instead of money. So for every 1.25 hours you work, they give you a session, which is 4 hours of clinical work. So in 3 hours, that's an extra day off. 12-hour night shift, that's 4 days off. It's like a week. It's amazing. So clearly we all just went, no, we don't want the money, we'll have the time. Because I can do something way more fun with the time. So after the first 2 strikes, suddenly they all realized that we all had about 5 months of annual leave. And they were like, guys, can we pay you? And we're like, okay, 270 quid an hour. Can we pay you less than that? Okay. So this was an ongoing wrangle. So what changed early? The nurses and physios, radiographers, they rolled over early in May. They started striking about 6 months earlier. So they took a £1,600 one-off payment, 5% pay increase, with a promise to review the year after. And they were all super happy. And the strikes kept going on, and, you know, there you go, Wally and Vivek sitting there going, we're quite worried about you guys. And I love this one. It was a really long strike. Where is it? There we go, blah, blah, blah. 5-day strike. Because we're worried, we only want you there on the Thursday between 8 and 10. That's all the picketing we want to do because, bless you, you're so tired and overworked. So they launched this thing called, yeah, go for a walk. The hike for a strike. Brilliant. It's all good. Go and have a braai. Brilliant. So anyway, after we covered it, we decided we were going to launch Bike After the Strike. And what a team to take mountain biking with you, right? I mean, whatever we broke, we had somebody there to deal with it. So this is me with 4 of my colleagues who we all discovered we're all mad keen mountain bikers, so off we went. Unfortunately, we don't have this weather, so I had the privilege of going out biking with Fikey. We don't get blue sky, we don't have the sea, we don't have mountains. We have mud and we have trees and we have rocks. So this is my local mountain bike park. So if any of you ever get a chance to come to Bristol, you can come and join us and do that kind of stuff. So the government then started slating the medics and just saying, you've destroyed the healthcare system, you've pushed waiting lists through the roof, people aren't getting operated, cancer patients are dying because you're all money-grabbing, greedy doctors. So the blue arrow is when the Conservative government came into power, and the orange arrow is the first NHS strike. So the system was already destroyed before this all happened. But again, it's just spin in the media. Changes in waiting lists, again, pretty much flat-ish compared to when the Tories started to where the strikes were. Size of diagnostic waiting list, not really any big change after the strikes. Cancer patients waiting over target, again, already a disaster before the strikes started. So what happened next? Well, the consultants had had enough as well. We thought, right, you lot can cover our jobs instead. Oh, but you can't, can you? Because you can't work if we're not there. Okay. So anyway, the consultants decided they were going to strike, and actually the Junior Doctors Committee decided they were going to strike at the same time. So the entire workforce was going to be on strike together. No doctors anywhere. Brilliant. That was going to work, wasn't it? So there it was, all over the papers. But to be honest, most of us didn't strike because we were very conscious of the fact that the juniors were going to, and somebody had to be there. So we supported it. We did have solidarity, but actually we took a slightly more pragmatic view that actually we had to keep the wheels turning somehow, and we all chose to work. A lot of comedy in the media. You know, it was generally all quite good-natured. Public support was still there. And after the dual strike, Barclay gets booted, but I love it. He wasn't booted or sacked, he was demoted. Okay, very clear, wasn't sacked, demoted. And we got Victoria. There she is, lovely Victoria, wearing her grandma's sofa cover, looking stylish, fabulous. So she came riding in on a white horse, going to save the situation. She's going to sort out a fair and reasonable deal. And it became the most hateful phrase, fair and reasonable offer. Okay. So that's the damage that was done. So that's the sequence of strikes from when they started back in December 22 with the nurses, all the various bits, the zigzaggy ones as the consultants and juniors together, and the bottom is the number of hospital appointments, whether outpatients or operations, that were cancelled in each of those strikes. It is absolutely terrifying, the impact it made. So they finally decided that they were going to target the consultants. So they came with a deal in January. They were going to reform pay progression, shorter intervals, so you'd hit the top band a lot quicker. They weren't going to do anything to the review body on pay. And they came up with this great plan about SPA, which is our supporting professional activity where we do all our research, the things that we do to keep ourselves current and trained, that at any time your trust just went, actually, no, you're not having that this week, you're just going to do clinics. Strangely enough, we all went, no, we're having none of that, sorry. And unsurprisingly, with that great pay deal, the nurses all went, what? So this was the next thing. Following week, the nurses went, right, we're going to ballot, we're going to go and strike. We shouldn't have rolled over on 5% and 1,600 quid. We want that now. And it was like, oh, God, here we go again. Still waiting to see what happens. And then only in April. It's that close. So the consultants ended their pay dispute. And we ended it with an accepted deal, which basically the DDRB has to be completely reformed. They've backed off from the reallocation of our supporting activity time, and there's going to be medical representation on the DDRB going forward. So not too bad. Realistically, financially, we'd be no better off, because what they've done is taken away our excellence awards to pay for the pay rise, and it'll push us into a higher tax bracket, so the money will all go back to the government anyway. But actually, it's an independent pay review process, and that's pretty much all we wanted. So looking at the overall impact in terms of lost revenue and what it's cost to cover those shifts is currently in excess of £3 billion is what this strike process has cost. I've no idea what that number is called in real life, but it's a shitload of rand. Yeah, it's a lot. There's been over 2 million hospital appointments cancelled through this process. They looked if the original offer that they made of an instant 26% rise was granted on day one, it would have cost 1.2 billion. That was it. So this is just going on and on and on. So the trusts have lost revenue. There's a massive backlog of the non-time sensitive. So most of the cancer patients got through, the infections, the traumas were all managed. The medical profession is probably stronger now than it ever has been. And the Conservative government is predicted absolutely catastrophic loss in our general election this year, unsurprisingly. So Wally's looking a little bit broken. Even he's looking tired of the strikes now. Victoria's still wearing a granny sofa. And it's absolute radio silence. Like nothing. There has been no word about a new pay deal, any negotiations, strike dates, anything from the juniors. So everybody has no idea where this is going next. So it's still rolling. We have no idea. So essentially, what do we learn? We think we've got to stand united, whatever happens, how difficult it might be. If you do come to understand your colleagues will all deal with the situation differently. We're all different people, different personalities. And I think the key is you just got to work together and manage that as best you can. Use it as an opportunity to revise pathways, things that you may not have realized were being inflicted on your juniors, and change life for the better for them. They've come back very much more positive about the changes we've made for them. And as I had to say to our CD, this isn't personal. This is a national body against a national government. It's not 8 junior doctors making war on you. Just take a step back. Take time to operate with your colleagues on something new, things that you don't do very often. Go and learn. It's great. It's really good fun, good refresher. Organise a social program. That was really good. And probably what we did notice, we're all passengers when it comes to this as a national process. But we're pilots locally. You're only in control of your own native environment. So do what you can within the constraints just to keep the wheels turning. Deal with the acute patients. But apart from that, it'll wash over you. So that's kind of the real story behind the media. I hope it doesn't come your way and you don't have to go through this, and it is quite painful. But if you do, I hope some of that's helpful. Thank you. Right, that rubbish is over. We can go back to the orthopaedics now. Perfect. Okay, great. Distal humerus, the other end now.
Yeah, thanks, Steve. Very sobering talk. Having worked in the NHS years ago, it's, yeah, not nice. A lot of paperwork. Yo. Okay, so distal humeral fractures. So this is a very busy slide by Sean O'Driscoll's group. Really, this is the sort of his template for managing distal humeral fractures, intra-articular, extra-articular, and I mean, this group at the bottom, from my experience, there's not a lot of places who are doing total elbow arthroplasty for these fractures. Certainly in the state sector, it may be different in the private sector. So I'd be interested in any of those who do work, just to share some of their experiences there. So again, similar, has just got quite a few cases to discuss. So the first case is a 30-year-old female who had a fall onto the left elbow. And these are initial x-rays. Any comments as to what you'd like to do next? She's neurovascularly intact. It's a closed injury. Would anyone get a traction view, or would anyone get a CT scan, or what would people do? Traction view. CT.
Will answer you.
Okay.
Just throw it. Just throw.
Boca. That thing.
Yeah, the good news is that you get to pick the next person as long as you're a good thrower.
Yeah.
Okay. Yes, distal humerus fracture. I think a CT scan will help us to identify, especially it still looks intra-articular, but a CT scan will just show us the intra-articular extension and yes.
They're all going
Okay.
at once. I don't know how I managed to do that. That's quite cool. Yeah.
Yes, and it will also show us the displacement, the angulation that we have on that element.
Okay, so what would you, given this information, given her age and what you've seen, how would you approach this now?
Okay, I'll counsel the patient that to be able to get on top of this is to get a stable fixation that will be open reduction and style fixation with plating. That will be by columnar plating.
Okay, and how do you position your patients for that?
I position my patient prone. I apply a tourniquet. So I approach the patient posteriorly with the prone position.
Okay.
And I approach is intra-articular, so I prefer to do electron osteotomy.
Okay. What type of electron osteotomy do you do?
Chevron. I do chevron osteotomy, yes.
Okay. Of those who do electron osteotomy, is everyone doing a chevron? Is anyone doing anything different? A flat oblique or a step cut osteotomy or triceps reflecting? No? Okay. All right. A show of hands, would everyone do an electron osteotomy in this case? So sort of about only a third. And the rest, would you try paratricipital and through windows and see? First. Okay. All right. And if you do a chevron, what sort of fixation would you do?
Sorry to interrupt you there.
Yeah.
While we're talking about the approach, has anyone tried the extended posterior approach with the unconius flap.
I have, yeah, the so-called trap approach.
Yes, the
Driscoll.
trap approach.
Yeah.
Yes, yeah.
Yeah.
Has anyone tried that before?
Not for a distal humerus, but yeah, for a big exposure for the. So if you've got a transolecranon fracture dislocation, I mean obviously the olecranon comes off, but you have to take anconeus off anyway to get exposure. But,
All right. That's
yep. So most people are doing this prone, are they, or are some people who's doing it laterally? Okay, you've got good table sets up. That's good. Okay, so we did this paratricipital. Any comments on the fixation? There's a bit of a step here. Okay, plate's a bit longer. I guess there's no stress riser. It's not a great X-ray, to be honest. This screw looks a bit dodgy. It's probably is it in bone? Don't know, but she did okay.
Someone who wants to comment?
Yes, please.
I don't know if I wanted to, but yeah.
Huh?
No, I thought it looked okay. I was wondering why the plate was so long.
Yeah, I think it might. I think it might have been dropped. I don't know. The correct size might have been dropped.
Oh, okay.
It happens.
You know, it does happen. It definitely happens.
Yeah.
And my colleague was asking whether the screws are they not in the fracture sites, or we trying to.
Which ones? These ones. These ones here. They're very close, aren't they? There's quite a bit of comminution there, so yeah, it's close, but seemed like it healed. So
Looks good, but just long.
okay. Of those of you doing a chevron osteotomy or olecranon, what are you using to fix it? Who's using a plate? Everyone. And are you pre-drilling your osteotomy with the plate on and then reflecting it with the plate on the proximal fragment? Yeah, and clipping it. Okay. Who's using a screw with a tension band? Okay. It's interesting how. So there's actually not a lot of literature on doing, the outcomes of plate fixation of your chevrons. I couldn't find a lot in the systematic reviews that are recent. So that's something that we don't really know. So these are your options for approaching the distal humerus, your paratricipital, the tricep splitting. It doesn't that doesn't really give you a great view of the intra-articular if there's an intra-articular component. It's fine for extra-articular, but it's difficult to get around. Your triceps reflecting this so-called trap approach, and then the olecranon osteotomy. I'll move on. So we've got a 20-year-old female, pedestrian vehicle accident with a left elbow injury. What would people's approach be to this? This is a bit more comminuted. Yeah. It's someone's. That's like a Scottish throw, that on there. Okay. Didn't go to hand. Okay.
We'll get a CT on this one.
Okay.
What is it particularly about this one that makes you go for a CT?
This looks a bit more comminuted, more intra-articular. I want to see if there's little fragments, if I need, what to order, what size lag screws to order. So you'll do probably a olecranon osteotomy for this. Lateral side, same setup. And
Okay. You wanna
try
see
and
the
reconstruct
scanning?
the
Sorry.
block first, and then do bicondylar plating.
Okay. So, moving on, we did do an osteotomy. So the plates are quite prominent on the medial side. This, any comments? You make comments. Maybe who have we not heard from? Back middle, Steve. Back middle, or you can handle.
The medial plate to me looks a bit short. Yes, the plate, yeah, going proximal, it's a bit short. That most distal screw is pulling out, and the plate is not sitting on that medial epicondyle. I don't know what's happening to that distal screw on the posterior plate.
This one.
Yeah,
So
that
this
one.
has got it's got a flange. So it's got a flange, so you can actually do your lag screw from the plate. You can, in some of the systems, you can take that off. So again, it's modular. So it allows you to do a trans, to join your to join your condyles up. And it's quite prominent there. Okay. Yes. Yeah. I agree with you. It didn't slip down, but yeah, that's what it was.
Yep.
Sorry.
Yes.
Can I just ask, how was the ulnar nerve clinically after the operation on this patient?
Ulnar nerve was fine, intact.
That's fine. Yeah, and then I just wanted to note some people don't like the olecranon osteotomy because of what possibly might have happened there. That joint doesn't look like it's well aligned. It's well aligned.
Yeah. It's not a true lateral, but I agree with you. There is a slight step.
Yeah. So some people prefer not to cause problems where there were no problems in the first place.
What do you mean? Sorry.
Because this patient might end up with a post-traumatic osteoarthritis in the elbow joint if the joint is not well aligned.
Okay, but
Yeah.
I mean, if you're going to do an osteotomy, you have to. I mean, where do you? There is a bit. The bare area is where you try and put your chevron. Where, what do people use as landmarks for the bare area? Do you expose it fully before you do your chevron, or?
No, not really.
Not really.
Yeah.
Who looks for the bare area first? Visualizes it. We've got a handful. So how do you know where it is then? How do you do it? Do you look at the triceps insertion and then just track it down, or how? Yeah. Yeah. So on average, the bare area is about 21 mils from your triceps insertion. That's an average but it does differ in populations, and it's about 4 mils wide. But again, it can vary as well, patient population to population. So, yeah. So this so this, I can't remember how long this was. I think this was about 3 months post-op. She had actually excellent range of motion. She was doing well functionally. However, she had a small sinus over this distal end of the plate. So she actually we debrided that wound, took some deep specimens. It's a very tricky area, obviously, over there, olecranon, to deal with. And only being 3 months, would people have removed that plate at that stage, given this X-ray? 3 months? Would you debride, get your specimens, and then see what you grew, and then take it out a bit later?
Yes, yeah. Just do it there, and wait for your osteotomy to heal. Yes, yeah. If you are in doubt, do a CT scan, and look at whether the osteotomy site has healed or not. Yeah.
So we did wait. We didn't grow anything. This was just a wound dehiscence. But when people are putting their plate on, so if most people are platers, are you using? How are you managing the triceps? Are you making an incision in the insertion to sink it down, or who's just laying it on top? Maybe show of hands. Because I just laid it on top. That was what I've been doing in my training. But who's making an incision to put the proximal? So yeah, maybe I should now. Okay. I've always thought it's, double-edged sword. There's no difference functionally, but yeah, certainly in the young thing patient, I think it's a good idea now. Okay. So she had a dare, and we eventually took the plate out, and she was actually okay. So the olecranon osteotomy, these are the types that are described. So there's the chevron, there's the true transverse, or there's this sort of flat oblique, which is like a transverse with an oblique cut, and then there's the step cup osteotomy. For the chevron, who's doing it? So there are different types of chevron. I know in Asia they're quite interested in doing an anterior type chevron, so they make the cut in the AP plane, whereas we're more taught in the sort of transverse plane to come down sort of 20 degrees. Is anyone using a jiggly saw? Is everyone using a power tool? Or how are people actually performing? Yeah, everyone's got power tools. You're lucky you have that available. Okay, because a lot of hospitals don't have a micro saw. Okay, I'll move on. 66-year-old female, again with a pedestrian vehicle accident with a right elbow injury. So, do people want a CT in this one? People nodding? No. Okay. So markedly displaced, medial condyle is in pieces. What to do? So this was very much a challenge. She was very, very osteoporotic. The trochlea was very comminuted. We planned to headless compression screws, but really it was just there was actually no bone on that medial side. So it's a terrible X-ray. Apologies for that, but that's what all we could get post-op. So, what would you do now? Who would have seeing the CT and given her age and her bone quality, who would have planned something else? Would anyone have done an arthroplasty primarily in this? Or at least had one
Can you go back to the plane films? And what age was she?
66. Low demand. Yes.
I mean, on these X-rays, she's actually got good bone for her age, and the fracture.
It looked like good bone.
Oh, it looked like good bone. Yes. What's concerning is just the avulsion fracture fragment, right? The other two look like if you reduce the humerus, it will be okay with the capitellum and the trochlea. But it's actually the avulsion of the medial epicondyle, because not only is that insertional site for the flexors, but also your LCL.
Mm.
So that for me, that is the most concerning. But I would have still given it a chance with an ORIF.
Yeah. So that's what we did, and this was the immediate post-op. So we tried our best to reconstruct that articular surface, and she comes back at 4 weeks with this X-ray, with sinus over the distal end of the wound. CRP is 350, white cell count is 12. She's systemically well, but it's 4 weeks. What would people do now? Where's Boca?
Where's Bocky? Just send him.
Yeah, it's definitely a Scottish halfback, that.
Yeah, it's she's developed post-operative infection. I would. We mentioned this earlier, where it's better to have a united bone in the face of sepsis than remove everything. So, I would try to treat that, treat the infection locally, try to promote bone healing, and at a later stage remove the plates. But I'm quite concerned because he's quite elderly, soft osteoporotic bone. There's a high chance of non-union over here as well. So if in terms of the sinus, we can do a pus swab, do an MCNS, see if we can grow anything, put on antibiotics, and then see how that goes.
Thank you. Anyone else? So we've got, you want to do a dare, do you? You want to do a debridement and keep the implants as much as possible. Okay? Anyone else? Yes.
I think I would also opt for a CT scan maybe first, just to see if there's union there, and then I'll remove the implants.
I don't have the images, but I believe it was done. Just showed those headless compression screws are just floating in the breeze, floating in the joint.
Just a question from my side. I don't do much upper limb, but if you're thinking of doing a day, you have to ask yourself the question, is the implant stable? You know, there's no point retaining the implant if it's not stable and you're worried it's not, you know, you're not going to take the patient to union. So then you need to intervene and do something. So, yeah, you just
So
need.
what are you saying? Are you saying you try and refix it? So it was challenging the first time round because there's not really bone stock. So how are you going to make it stable now? So are you going to excise all the dead bone if you think this? If you know, I haven't got there yet, but if there is dead bone, you're going to take it out. You're going to take the implants out and refix it, or?
We're probably heading down one route, a replacement route, but not now.
Yeah.
I don't think. Yeah, you have to control the infection, remove all the dead bone, perhaps stage it, and you probably won't have anything left after you've excised most of this dead bone.
Anyone else? Yes.
Yeah, I mean, this unfortunate lady, she's got sepsis. She's 4 weeks down the line. Everything has collapsed around there. So, unfortunately, you cannot retain the implants because they're just swimming in a pool of infections. My approach would be possibly just to remove the implants, debride, and I would contemplate putting an articulated external fixator with HA-coated pins. And start her moving. I'm going to the terms to what we were taught for the Rice-Barrow and Redine type 4s, where patients could be treated in a form of, I don't understand the term, but supervised or skillful neglect, where you just have a bag of bones.
Bag of bones elbow, yeah. Okay.
That's basically where I would be going to. 66, low demand.
Steve, what would you?
Yeah, I mean, you know, I don't do that many of these. I've got upper limb colleagues who deal with them. One of the tricks he's got for these very sort of fragile, sort of multi-fragmentary elderly ones is he takes medical photography to theatre with him, and he has arthroplasties there. And the ones that he looks at are just completely sound similar to this, totally shot to bits. He just puts all of the pieces on the table and just gets a picture taken to it, does his arthroplasty, and he goes and sees them afterwards and goes, that's what you had. And she's relatively youngish, I guess, 66, but not high demand. Maybe it's fine.
66 is old in South Africa.
Yeah.
I
wish. Jesus. I mean, most of the ones we get about 96. But I think once you're into the realms of, I think the infection overrides everything here. So, and I think the point was made that we've got no structural role for that fixation anymore.
Yeah.
It's failed, so it's not doing anything. So for me, that'll all come out. Anyone got any other strategies other than articulated external fixators for these? Does anybody like internal treatments for these if they're managing infection? Better than X fixes? I'm not a massive fan of upper limb X fixes. Andy, thoughts?
Yeah, so so I'm come late to the party, so just tell me to shut up if this has all been said before. I think the basic principle here is where the problem has started. If you're going to fix an elbow, in my opinion, it must be strong enough that you can move that patient immediately post-operatively. So this fixation was doomed to failure from the very beginning. So I kind of agree with what Steve's saying. I would have had an arthroplasty available and potentially have gone to a primary arthroplasty for this patient. Now you're in a situation where you really are doomed to failure. Everything must come out. Debridement, get rid of the infection, and if you can get rid of the infection, head for an arthroplasty. I don't like external fixators. Elderly folks don't do well with the articulated X6. There are two different types. There's that big heavy type, which is a disaster, and the very light type, the Mori type fixator, is potentially better, but it doesn't give you enough stability. And articulated X6s, the elbow doesn't move around a direct hinge, so it's quite tricky to get it exactly in place. This patient's not a good candidate for an infix. There's not enough bone, for that to take place. So I'll take everything out. I'll probably just keep her in a splint for a while, let everything settle, and pray to God that you can get a implant in at some stage.
Thank you. Okay, I'll move on. So I hear what everyone said. I took her to theatre, and I did debride it. We grew a staph aureus, and we just did the one debridement. She actually responded very well. It was a sensitive staph and MSSA, and she actually is, has been cancelled. This is her 6-month X-ray, and she's actually functioning reasonably well. Doesn't want any other surgery. Wounds have healed. But I totally agree with everything that's been said. I think we will see her again, but maybe not.
Can I just add one thing? There's two patients with infections.
Yeah.
I actually don't believe a lot of these elbow things are deep infection. I think it's a vicral stitch in the subcutaneous tissue that caused a lot of trouble.
The first one was a dehiscence. It was a wound dehiscence from the plate prominence. And This one is a true infection.
It was a true deep infection. Okay, well, miraculous.
Yeah, miraculous, I know. Yeah. But I haven't seen her yet. Again.
Right.
Yes.
Sorry, just got one more here.
How much motion does she have in that elbow?
She has a range from around 30 to 100 degrees flexion.
Right. Just one thing in terms of managing these. I'm very much with Andy. I hate the X fixes on them, so it's quite nice just making them with cement coated threaded rods with a hinge off the Lazarov. I mean, it's not a perfect hinge in terms of getting it spot on, but actually it's enough to give them kind of a sloppy hinge mechanism, but still allow them a range of motion.
That's a good idea.
And it's really easy to just slide them out. You just decouple the hinge and then they just pull top and bottom, but at least it means it's a lot easier to manage dead space and soft tissue with it.
Yeah.
But
okay. Thank you.
Yeah, one more.
Just
Greg,
one more
sorry.
thing. I just want
yes.
comment there. Generally, when I do these cases, most cases, I don't like to leave K-wires in. I find them quite sort of irritable to the skin, higher risk of getting infection. I prefer to just put proper screws attached to the plate.
I agree with you entirely.
Yeah. So
I just didn't have anything to put screws in.
Okay.
It was just so brittle. I had to get some sort of fixation, and K-wire was all I had. That was gonna add something.
Plan C.
It was Okay. Case 4 is a 35-year-old lady, again another PVA, presents with this injury. Anyone like to describe what this is?
Go boggy.
And how you would approach it?
Wherever you want.
Yep.
Better scrum off this time. I'd like a CT scan again. I think one of the condyles is off there. And I'm worried about the comminution, which you can see there. Sure, this is a bad fracture, highly comminuted.
This is South Africa. We deal with bad every day.
Maybe go back to the X-ray so that you can
Sure.
see the X-ray,
Yes.
especially the lateral view.
Yeah.
On the lateral view, you can actually see the whole, it's flexed, so you can actually see it's, but the comminution is worrisome, which is why the CT scan, I think, was warranted, as you can see from the, it's misleading, this X-ray, but it's quite a bad fracture.
Where do you think that fragment is coming from anatomically when you look at the AP and the lateral?
I think it's from the trochlea, if I have a look at that there.
Partly, but mostly. It's
Oh, I
nice and rounded. It's in front of the radial head.
The capitellum.
Yeah. That makes sense. Because sometimes a CT scan of the elbow, especially when it's flexed or in a back slab, it's very difficult. But you can make out some stuff on X-ray. But look at the far right. The far right. Look at that. That's capitellum off, right?
Yeah, okay, can I make one point? I find CTs in the elbow very difficult to understand because you're changing from one plane to the next. And this is the one part of the body where I think 3D reconstruction actually does help you.
I was desperate to get that.
Yeah.
Our hospital doesn't do them routinely.
Is it?
Yeah. So,
Look, you can recognize the fracture pattern from the plain X-ray.
Yes.
So once you've seen it, you know what's going on. But 3D recon really helps, and that's the only time I like 3D recons.
Right, is that partial articular?
Yes. So, how would you manage this? Given what you have this, send it to the opposition.
Send it to the opposition, I agree fully. No, so it's partial articular, as we said now, so it needs to be restored anatomically. So I'll go for an olecranon osteotomy here and reduce that anatomically as well as I can. It's very difficult with all that comminution, but I'd want to visualize the joint because I think it needs to be restored anatomically. So I'd still go for an olecranon osteotomy with this patient and see if we can restore it. I'd have headless compression screws there, just because there's a large amount of articular surface you need to work with. I'll have the whole shebang. I'll have the plates there as well for stability more. But I think it's going to be very tricky.
Is there any other, anyone else have any other? Yes?
I would go with a lateral approach here.
A Cocker approach?
More of a Cocker approach, yeah.
Okay.
And anterior capsule is probably gone, but give myself room in the front there. Preserve the soft tissue pedicle on the lateral condyle at the back, because that's where most of the blood supply comes from, that lateral condyle. And then take out any loose fragments on the trochlea anteriorly, that's lateral side. That looks too comminuted to fix with any kind of headless compression, and then concentrate on the capitellum, getting an anatomical reduction, and put in either probably posterior anterior headless compression screws, fix the capitellum.
So you'd go posterior to anterior?
No. Through my lateral approach.
Anterior to posterior screws?
Posterior to anterior. Cannulated.
So you're going from the back forward? Yeah. Yeah. Okay. Okay. Okay.
100% what he's saying. percutaneously putting screws in, you can actually see where the wire comes into the joint. So you can measure it precisely, and that technique is going to work for this.
You don't have concerns about the blood supply because the capitellar blood supply is posterior.
Yeah, you're percutaneously doing it. So you're doing literally as through a poke hole, and you're looking at it from the anterior side. So everything is done anterior. You basically like a lateral condyle fracture, reducing it with direct vision across the joint, and then bringing percutaneous screws from the back.
Okay.
Yeah.
But
So
then
it's from the back to the front, and you can really get these things subchondral because you can actually visualize directly into the joint where that wire is. So you get a very, very accurate screw placement.
Okay. Yes.
I would do it from anterior to posterior. Go back to the CT scan. The far right, just play that on the far right. So if you want good purchase for the capitellum, it would be good to come from anterior to posterior.
And what approach
Because-
would you use then?
So I still approach it like posterolateral. So I would go a little bit anterior, so maybe the capillum, yes, so that I can see both sides. Sometimes even release. I had one last week. You actually even had to release the LCL a little bit, so I had to fix it afterwards. And once you have your elbow in extension, and then you reduce the capitellum, you can actually get 2 screws, headless screws in, and you bury them. So
Yeah,
for
I
the
mean these are
articulation,
difficult fractures. Yeah, thank you. Yeah, yeah. Yes.
Well, the problem is when you're trying to do that, I've tried to do that, and your angle of your drill doesn't go perpendicular to the fracture. Whereas when you go PA, you're getting it perpendicular to the fracture. You know exactly the distance between your screws. You know where the wires are coming out. You know whether you parallel. I just find that a better technique, because when I'm going this way from the front, you can't really go perpendicular to the fracture. And what happens then is when you tighten down that screw, the capitellum wants to drift medially. So I lose position that way. And working PA, I think you really get a good fixation. And you can even go with when you're going with the PA screws, you can even get 3 in there in a triangular formation, because you can go so much to the back and catch even the most medial part of the capitellum as well.
I hear you, but with the lateral approaches, because you've got about 3 or 4, so it depends on your configuration of the fracture itself, right? The line. So if it's more sort of anterior, you need position anterior-wise. That means you'll have to go more anterior on your lateral approach. So the skin, you can do the skin, but after that you have to then decide: are you going to go between your ECRL, ECRB, or are you going to go more posterior? So that you are guided as you go in, right? So then if your fragment is more in the front and your line of your fracture is difficult, then you go more anterior when you get inside. So that's how then you can guide where you can have a chance to actually go perpendicular. But it's never, I've hardly ever seen one that, it's rare to see one that is true AP to lateral. It's
Well,
always
also
a little
the radial
bit
head
off.
gets in your way as well.
Yeah?
Radial head gets in your way.
Yes, but you can with Homans and stuff going in. I'll show you. I've got the one that I did last week. I've got pictures of. I'll show you how I approached it. Yeah.
So, yeah, thanks. Very useful comments. I'll show you what I did. I used the Kaplan approach, and this was his X-ray at. So I went AP, and any comments? This was at 6 weeks post-op. He was pretty happy. Haven't seen him since. So it's not easy. So use 3 screws, and yeah. I'll move on. It's an interesting discussion. So 65-year-old female PVA with a closed left elbow injury. What now? Same formula. CT scan. So for me, when it has a lot of comminution in the trochlea, I find these very difficult. I think one of the comments earlier by one of the speakers is that This isn't the private sector where you're doing these within like 2-3 days. These are often waiting 3-4 weeks, and in my experience, it's to get the sagittal balance right. It's very difficult when its callus is already formed. You're trying to free it up, and you're trying to get the the shaft aligned with the distal fracture, so you can actually get the sagittal alignment. It's very hard when it's old. Without doing an osteotomy, it's incredibly difficult, and often there's cartilage fragments just everywhere. So the usual menu: chevron osteotomy and plates. 65 with that fracture. I'll just show you the X-rays again. Elbow replacement on standby. Yeah. That's what we did. She actually did okay. She's not septic, but yeah. I never saw her again. That was at 2 weeks post-op. It's not a great X-ray, so apologies for that. But yeah, we never actually saw her again. But it was a challenge. It looks very weird. I agree here, but the medial plate's slightly anterior. Yeah. Not really a lot more to say. 5 minutes. Okay. Case 6, fall down the stairs, 46-year-old. What would you do here? Get a CT. It's a similar menu, really. How do people manage the ulnar nerve? Do you neuralize the nerve, transpose? How do you, when you do your approach for these? Do you leave a cuff of muscle on next to the nerve, or how do you manage it? Do you just neuralize it just where you can see it around the medial epicondyle? Do you go all the way down to the FCU, or?
Yeah, the ulnar nerve is a funny thing because, if you're doing an ulnar nerve transposition, that's a big operation in its own right. So now you're going to start that operation before you start your osteotomy, which is also a big operation. Then you're going to do the fixation. So you're now doing 3 big operations. So I think the ulnar nerve dictates what needs to be done. If you can get away with putting a plate underneath it, I haven't seen problems with ulnar nerve hassles. If the nerve is unstable, if it's in the way, then you have to move it to the front. But it's a big operation. You've got to spend a lot of time. You've got to do it properly. You've got to create like a sling to hold it in the front. So it's not it's a little blithe comment. I just transpose the ulnar nerve. I don't think it's as easy as that.
And what sort of transposition do you do? Do you do
in this situation, definitely no. This will be subcutaneous, yeah. Unless you've got one of these little old grannies who's got like skin and bone, because then you're asking for trouble at the end of the day.
So the literature says that you shouldn't do much more than just move it out of the way. Neurolysis, that's it. Try not to transpose unless when you're examining it and after your fixation, it's sort of impinging on your medial plate, then there is a role then, but that's really the only.
100% agree with that. The other thing that petrified me for a long time is that you skeletonize that ulnar nerve from halfway down the triceps to the other side of where it's going into the forearm. And you're now sitting with a nerve. Where does blood supply come from? Fortunately, so I'm told, if you want to see really excellent nerve work, this woman, Elizabeth McKinnon, a plastic surgeon, she's got a whole lot of YouTube videos. And she says 80% of the blood supply comes from intraneural. So that's made my heart feel a little bit better, because I always thought you're skeletonizing these things. But try to do as little to the nerve as you possibly can.
I think the other important thing is whatever you do to it, document it. Because somebody's potentially coming back to revise it, and it's just nice to know what's been done. So whatever decision you make, just be clear what you did to the nerve.
Yeah, so that's a really good point. So what I do is I make a note where, in my notes, where the nerve is going over the plate. So we say at the third hole or at the second screw, whatever it is, that's where the nerve is. So it gives you like a ballpark idea if you are coming back to take out your septic plate, where the nerve is. Yeah.
Has anyone got a sort of menu of how they find the radial nerve when you have a distal humeral fracture that extends up? How do people mark out where the radial nerve is?
Carefully.
Slowly, carefully.
You know, it's always
what
higher than you
landmarks do you use? Do you use a bony landmark? Do you use
no.
a soft tissue? Or?
All of those things are nice in theory. I think in actual practice, when you've got a broken elbow beneath you and a hand's breadth and this and that and the other, doesn't really work. But if you just gently go through and it's always on the bone. So if you just put your finger up there until you can eventually start feeling it, and if you get a twitch, you know you're getting close. And I'm not convinced that landmarks are because that's 80%. But if you blithely going ahead and it's not quite where the landmarks are telling you, you're going to stuff something up slowly and gently.
Yeah, so there's a lot of interest in that in the landmarks. Yes.
Just another comment.
You can actually, once you open and you got underneath the deep fascia, you reflect the deep fascia, you'll see the posterior cutaneous nerve of the forearm coming off the radial nerve. If you follow that back, it takes you to the radial nerve. It sits in that gutter, lateral gutter. And you follow that back. I don't know if you've done the humerus exposure, the Gowan modification of the paratricipital approach, where they reflect the whole triceps medially. And that's how it tells you to find the nerve. So you follow that nerve back, and it will take you right onto the radial nerve. That's the method I use.
Does anyone have any other? Thank you. Any other ways of finding the radial nerve? So there's a lot of interest in what's called the point of confluence. So where the triceps aponeurosis, where you see it becoming muscular with the lateral head and the long head. If you dissect 4 millimeters above the triceps aponeurosis, that's a safe plane to start dissecting for your radial nerve. And they've actually, there's quite a good cadaveric study looking at multiple populations. So 4 mils is the magic number. So if you go 4 mils above that, and you can make a sort of 2 centimeter split in your triceps, and it's never less than 2 centimeters from there. So 4 mils just above the point of confluence, and look towards the lateral head. So that was, yeah. I think I'll stop there. Yeah. Yes. Any questions?
Can I ask, do you ever do parallel plating? And what's your views on parallel plating?
No, I have previously. I don't use parallel plating. I think I have to dissect a lot more. On each dissecting to get your medial plates, you have to dissect quite a bit, and laterally you also have to. And sometimes when I do them prone, I just sometimes find to get that sagittal balance, the posterolateral plate helps you get the fragment, the distal fragment, into more flexion, which is what you want. I just find it. The literature is clear. The parallel plating is biomechanically better, but you're talking. You're not gonna say to them, off you go, load 10 kilograms straight away. They just, it's not realistic. So, okay, I'll stop there. Thanks.
Cool. That's great. Thank you. Okay, Cynthia. Close the show.
Yes. Ladies last, not ladies first. So I'm just going to cover a few cases, distal radius and carpal injuries. And because most of us here deal with distal radius fractures, I'll just present one that might be, well, it's quite rare, but quite interesting. So in view of this talk, we must just look closer, like Simba was told by Rafiki. Look a bit harder, look beyond what you see. And then at the end, you will have an untrained eye turning into a trained eye, so-called the Lion King approach. So I'll just discuss fracture dislocation, dislocations, and complex case. So I'll start with this one. Where's Boki? This is a 36-year-old injured by a tire explosion when he was changing a tire. Where's Boki? Who's gonna take a, okay? Spannenberg, yeah?
Okay, so we got looking at wrist, right wrist, obviously an open injury as well. Just looking at the lines, there seems to be a fracture, I think, of the distal radius. We don't have a lateral x-ray here by any chance.
Okay, so you want a lateral x-ray. Yeah. Okay, so I'd actually put in normal x-rays here, because sometimes it is quite difficult to see. So there's the lateral.
Yeah, so it's, on the lateral we can see there's carpal dislocation of the wrist with almost a volar Barton type fracture.
Okay.
Yeah.
So going back.
And obviously appreciate the shortening of the carpus onto the radius, and it's obviously volar displacement of the carpus onto the distal radius.
Okay. And then looking at the normal x-ray, lunotracheatrium, what do you think is happening here?
Very difficult to see. I must say there's quite a bit of bony overlap. Just looking at the gallulus lines, not too sure, to be honest.
Okay. So you'll see it later. So on this x-ray, what other injuries are there? So you mentioned distal radius.
Yeah, distal radius. So looking at the perilunate as well, I think.
Okay. So there's a small fragment fracture.
Yeah.
That seems to be going with the carpus.
That's right.
Right? And then the distal radius is left behind.
That's true. There's a P1, there's a thumb phalanx fracture.
Okay.
Yeah. Intraarticular.
Intraarticular wide type.
Yeah.
Mm-hmm.
Then, yeah, there's another fracture there. I'm just wondering where that's coming from. The scaphoid.
Mm.
Yeah, scaphoid.
Mm.
Right.
There, the scaphoid. So there's a fracture there. Okay. So those are all the injuries, including the open wound with the first dorsal compartment tendon injury. So what would you do for the patient?
Yeah, so it's a young patient, open injury, so you're going to go in open, your debridement, washout, antibiotics, and then you need to address the fractures on merit. So the distal radius, you obviously want to fix that. Just trying to think if we may need a CT scan just to make sure we haven't missed anything else.
Okay.
Otherwise, from what we have so far, probably distal radius plating, and then scaphoid as well. Do open reduction from the volar aspect. Fix the scaphoid on merit, probably with a scaphoid screw, and then sort out the distal, the thumb P1 fracture as well.
Okay. So would you just order?
Sorry,
Yes?
sorry, Cynthia. Maybe I missed it. Did we say the diagnosis? Because I was interested in that. I was just waiting.
Yes. No, he said it's a volar button type. So I will explain that later. But he said it's like a button type, volar distal radius fracture.
Oh, okay. No, with the carpal injury, like the whole diagnosis of the injury.
Oh.
Yeah.
He thought that there was a perilunate, but there actually isn't.
Oh, okay.
Mm.
All right. Okay.
Okay. So, are you worried about the type of plate you're going to use here?
Yeah.
Or do you think you need to order other things to assist with this kind of?
Yeah, you may need fracture-specific type plating here, because
Okay.
I'm not sure if your plate is going to be able to hold that up. So you may need fragment-specific plating. Sorry, that's what I was
Okay.
thinking of. You may also have to have an X-fix as a backup as well, just to try get your length out. If you
That's
struggle.
good for
Yeah.
traction, intra-op. Okay, so the diagnosis here is actually a fracture dislocation. It's almost like having an avulsion injury of the anterior rim of the distal radius. So this is actually more a ligament injury, right? Fracture dislocation. So went in, and I just extended the wound from here to a Henry approach. And what you're looking at here is actually the pole of the scaphoid. So this was very unstable, and this is this fragment here that I open a haiki. It's this fragment. So when you open it, you can see it's actually unstable because it's a ligament injury more than anything. So you know that you not only have to buttress this fragment, but you also have to fix the ligament injury that the patient has.
Out. You see the bumps there? Or not?
So this is the plate I opted to use. One, because it gives you an option of fixing the capsule and the ligament through two holes here. You've got two holes at the end, and it also adds to your buttressing. Then I also fixed the scaphoid, and this is lunotracheal collision. So I always wonder when I see unusual fractures, and I see these types sometimes when there is a collision. So it changes the biomechanics of how the injury occurs. And then intraoperatively, after fixing it, then I tested if it was actually still subluxing or not. Obviously, the fellow having a heart attack because I was testing also the scaphoid, which had a bit of movement. But I say you rather test your work intra-op, and if anything happens, you can then fix it. So it was quite stable afterwards.
Can I just ask, was the plate necessary here? Could you have just used maybe anchors to fix that ligament rim avulsion?
Yes, the plate was necessary.
Yeah.
Let me go back. So just looking at, I'm just trying to go to the video.
You can see it, yeah? Start.
So the plate is necessary. If you look here,
Okay.
so that is a significant fragment that you need to buttress. This
Subluxation.
on X-ray it might look quite small,
Retraction.
so it's not enough just to have cannulated screws.
Here's the
That is quite a significant fragment
reduction.
right there.
Right down there.
So in the fracture, as you can see, it goes even proximally a little bit. Yes?
Sorry, did you fix the ulna first?
The
ulna, did you
yes,
fix
I did.
it before?
Yes,
Otherwise,
I did.
okay.
Because that was the quickest, yes. Yes, I fixed the ulna first, yes. That's just the... So obviously the anticipated problems with this kind of injury, because it is ligamentous, just to go back here, it is ligamentous. So I knew that he is going to be stiff in extension with mobilization of the wrist. So I knew that I might have to go back and remove the plate and maybe even do not only manipulation, but do a bit of release of the capsule anteriorly. So as you can see, post-operatively, he did actually struggle with extension and a bit of flexion. Not so much the rotation. He was not too bad with the rotation movement. And he had good grip strength. So I did actually take him back to remove the plate and did manipulation just to get him extension, because patients usually would complain about either extension of the wrist or rotational problems. So he had he couldn't extend the wrist very well, so therefore his grip strength was a little bit less. So it changed a bit afterwards. So just to go over these kind of cases, you said that it is like a volar button type. So this is a button fracture. It's still continuous. The radius is still continuous with the carpus. And it can be volar or dorsal. This injury was a fracture dislocation, which is more a ligamentous injury, high energy injury. So these are usually common in young adults, and they occur with open wounds, like in our case, sometimes median or ulnar nerve injury, and some tendons can actually go into the fragment and stop you from having a good reduction. And sometimes you should actually have a CT or an MRI because it is a ligament injury. So in classifying them, you can either look at if it's associated with carpal injury, or if the fragment, a fragment is a big fragment or not so big fragment. And fixing them, this is the armamentarium you take in, external fixator, anchors, and specific plates, basically. So the important thing is to provisionally reduce the radiocarpal joint, then decompress the neurovascular structures, get a good exposure, debridement of the joint, and treat the intercarpal injuries. He had a scaphoid fracture. And then you can use a external fixator initially just for traction, but then ultimately fix the fractures and also the soft tissues. So he had extensor tendon injuries. Just to look at the column kind of system, so depending where your fracture is, on the radial border, intermediate, or the ulnar, you check stability, just like I checked in the x-ray post-operatively. And then if it's unstable, then you have to then go and fix further ligaments. So this was just me looking into how many of these actually go into post-op or post-traumatic OA that need maybe a wrist fusion. And this paper looked at 41 of those patients, and only one needed a total wrist fusion, and then one needed a radiolunate fusion. So even if they develop arthritis, chances are you don't really need to do a fusion for them. So this is the second case with Boke. So these ones I put in because I've recently seen a couple of cases that have been missed, subtle ones. So I've tried to put some subtle, but some obvious. So 24-year-old punched a wall.
Can you hear me?
Yes.
So, open or closed injury?
It's a closed injury. This is the patient. This is the patient's hand.
So, the obvious one is the base of the fourth metacarpal, and I'm not sure what that metallic shadow is over there at the base of the fifth. I need to see a lateral X-ray also.
Okay. So there's your oblique view and the lateral view.
So, looks like a fracture dislocation, at least at the base of the fourth.
Yes.
Of the carpometacarpal area, and that's why the prominence that you can see besides the hematoma on the image which you had up initially.
Okay.
I am struggling to see the base of the fifth.
Okay. So what if I said this is actually the fifth? Remember you said you saw a shadow, metallic looking shadow?
Yes.
That was associated with the fifth. Because the fourth was quite clear that it
Yes,
was a
yes.
fracture
Yeah.
at the at the metaphyseal area. So looking here, the one that gave you a shadow, it's this. It's this fragment. What do you think this fragment is?
Well, it looked very metallic on the AP picture, but
Yes,
not,
it did.
not so metallic.
It's not,
on the,
no.
on the
It's this fragment here.
Yeah.
Yes.
Yeah.
Because if it's displaced, you're
Yeah.
looking straight at it.
Yeah.
But then now, it's this. So there is a fracture.
There's a fracture dislocation there.
Yes.
You know, I mean, at the base of the fifth, we know that, you know, where it sort of attaches the extensor carpi ulnaris,
Okay.
pulls it across.
Okay. But this fragment looks like it's coming from the carpus.
Yeah.
The hamate,
Well, that's yeah.
because we can't see the hamate very clearly here.
Correct.
Can barely see the
Yeah,
hook
yeah.
of the hamate, but you can't see it very clearly. So how would you manage? Open reduction or closed reduction?
I would be ready for both.
Okay.
Okay. I would try a close reduction, check under image intensifier what's happening.
Okay.
And if I'm unhappy, then I would probably open it.
Okay. So I went with open, looking at this fragment, because I knew it was coming. It was going to be coming from the hamate. You attempted closed, because sometimes even if you do closed, you can then maybe do percutaneous ORIF. So we went with open, and that fragment we're looking at, it's actually this fragment. And that was coming from the fifth fracture dislocation, because the fourth was just a fracture. So we then fixated with, so now you can see the fifth CMC joint there quite clearly on the hamate, which you couldn't see before. And this one, 37-year-old fell off a ladder. Next person. So here's the hand. It's got a bit of swelling on the dorsum of the hand.
It looks very much the same neck, and we see a lateral view.
Okay. Oblique and lateral.
Dislocation. This one looks like the fourth is the one that is dislocated.
Okay.
I don't see any fractures associated,
Mm-hmm.
unless I'm missing something.
So there's just a bit of avulsion there,
Avulsion
so
there.
ligamentous injury.
The fifth and fourth. So I'm not quite sure. It looks like the fifth is in position, the fourth might be out,
Okay.
dorsally.
Remember, both of them share the hamate,
They share,
right?
yeah, okay.
Yeah.
So
So it is common for both of them to be dislocated.
Yeah, I must say, I've never seen an isolated fourth. You can't get it.
You can't get it out.
It's you know, it doesn't
sense.
happen. So it has to be fourth and fifth.
Yeah. So this was a closed reduction with reduced with held with K wires. So in testing the third, it was also a bit unstable. So we actually put a K wire there as well. So why are these easily missed? One, because in casualty, sometimes a patient comes in with other injuries, and then when they do an x-ray of their hand, they just do an AP. They don't do a lateral and an oblique. So they get delayed in diagnosis and sometimes even missed. So just looking anatomically, which ones are stable, which ones are more unstable. Obviously the fourth and the fifth are quite mobile, because when you're making your fist, you're actually going into concave mode. So those are the ones that actually do get injured a lot compared to the first and the second. I mean, the second and the third. And then these kind of injuries can occur, especially with motorbike type of injuries. And this paper is from India, and they explained how you can increase your chances of diagnosing these. On the AP, you look at the cascade of your metacarpals, and they should all converge somewhere along the distal radius. And as you can see in this instance, the fifth does not converge with the others. And then you look at the Galila lines, and then the CMC joints are supposed to form sort of an M shape. And then looking at the different types, some are very obvious, either volar or dorsal fracture dislocations. So this is typically your less frank type of fracture in the hand. You can even get like the diverging ones like this. So they looked at their series and looked at how do they increase the likelihood of diagnosing these. Some can be very subtle. So what they looked at was if an orthopedic trainee versus an emergency nurse practitioner, looking at x-rays, what type of x-rays gave more information. So they realized that the AP, along with your posterior oblique view, because the posterior oblique view is the one that will show you the end or the posterior parts that are fractured of fifth and fourth, unlike the volar oblique. So that shows you more anterior type of fractures at the base of the CMC there. And then a true lateral. So if you can have an AP, posterior oblique, plus a true lateral, then you increase your chances of actually diagnosing these. Some are very obvious, but some can be as subtle as this, so you need those views.
Cynthia, can I just say one thing?
Yeah.
We're just forgetting one thing. It's so easy to diagnose this clinically because when you pick up the patient's hand, you have that little piano key thing. It's a very gratifying thing when it pops in and out.
Yeah.
And you can't miss the diagnosis if you actually bother to pick up the patient's hand. So it's one thing where we go CTs and everything else.
Yeah.
Just hold the patient's hand for a while.
Yeah. And even on the pictures that you saw earlier, the swelling was quite clear. It was around the fourth and fifth. So these are more, so this is more like an obvious one, where you can see even on the oblique view, even on the AP, this you would have been able to pick up. But some of them are quite subtle. Yes, even, yeah. So that one, you always have to prepare because this intraoperatively will realize that it's got a trapezoid fracture. So you must always ask for headless screws, just in case there's couple injuries. So for these, there's no broad classification scheme that has been accepted. But the null above looked at, is it just a pure dislocation? How much fragment of the hamate is actually fractured? How much comminution, basically? Okay, moving on. 43-year-old male fell and presents with a painful wrist. Who's next? Who's got Boke? Maybe the last table? Yes? Okay. Oh, she's volunteering. Great. Go for it. What do you think is going on here?
Yes. Oh, maybe I wasn't.
Yeah, we can.
Okay.
Yes, we can hear you now.
Yes, left hand or wrist, I would say. What's clear in there is the fracture of the scaphoid.
Okay.
It looks like the waist, and there's a healed ring metacarpal fracture.
Yes.
Looking at the gully lines, I think matching.
Okay, bad X-rays.
Yes, the lateral.
Okay.
It's another lunar triquetral.
Yes.
Yeah, but now also,
Yes, another
honestly,
lunar
yeah.
triquetral,
So
yes.
you know, if you see that, you see strange injuries. I'm pleased you said that because I've always noticed that.
Yeah, funny injuries. Okay, I know this is a bad X-ray, but what do you think is happening here?
I'm looking at the lunate and the quatrum.
Mm.
You know, it looks like there's a
Coalition
there.
100%.
Coalition there. The capitates seem to be in position. I mean, if you draw a line straight through to the middle.
There's some fragments there in the mid-carpal around the capitate that are suspicious.
Okay.
Okay, not very clear.
This one is not giving much.
Yes, but there is something happening with the capitate. So, I suspected that this is a greater arc injury. So, meaning transscaphoid, transcapitate. Although a bit rare, but because this patient has got lunotriquetral coalition, the forces had to exit differently, right? So opted for an ORF. So an opening, what you're actually seeing here is the capitate fracture, because on the lateral, as you can see, the lunate is more to the volar, right? So when I open from the back, the first I will see is actually the bottom of the capitate before I see the lunate, which is more anterior. So that's what you actually see here, right? And then that's after reducing it. Then I opted to do cannulated screws. And that. So you must always look a little bit harder when you see cases of lunotriquetrum coalition. You always have to look what other it can't just, it's hardly ever going to be just a scaphoid fracture. There might actually be other injuries.
Would the CT help you, Cynthia?
100%. But this was in the state and I didn't want to wait forever for a CT scan, so I went in suspecting that it was a greater arc. So I prepared for a greater arc. Okay, 16-year-old was involved in a school bus accident. When she came to, her hand was actually stuck just under the bus. So she injured her left hand. Who wants to take this on? So this is now on the complex side. Yes, Carrera? I know you do trauma lower limb, but just think outside the box.
Yeah, no, it's an open fracture of the hand with involving the fourth metacarpal carpal bone on the ulnar side, hamate.
Bag of bones?
Yeah, it's a bag of bones.
Yes.
Okay, obviously we need to think of infection, to prevent infection, debridement,
yes,
and restore anatomy, but I don't think you'll be able to restore anatomy. But first I'll debride, wash, and stabilize. I'm not sure if I'll put an X-fix here just to distract.
What's your next option if you can't put an X-fix?
K-wires.
Temporary, yeah.
K-wires.
Temporary, you can put K-wires, which is what the orthopod did from another province before sending the patient to us. So they tried to reduce as much as possible, still a bag of bones, and try to put as many, well, reduce and put K-wires temporarily. So this is her the day after she was transported to us, and she had a swelling, and I was concerned about perfusion, and not only because of the swelling, but remember this was a deep ulnar-sided fracture, so the ulnar artery, which she was fortunate, it wasn't actually injured, but this was essentially a compartment syndrome the day after her being transported for about 4 hours.
Also tendons, I don't know the state of the tendons.
Yes, no tendons are definitely gone, as you can see from this clinical picture, because you're now looking deep into the wrist joint. So ECU definitely gone, extensors of maybe ring and small. But for such cases, you must always look deeper when you take them for debridement. So then I actually took her to theater that very next day for compartment release and re-look debridement. So this is on re-look debridement, and then I document what the injuries are. So she had severe abrasions, some of them deep like a secondary burn on the back and the buttock. All the way through to the volar side, the FDP of the small and the ring were injured, and partially of the middle. The extensor tendons damaged, ECU, and also ring and small extensors. And then you have just this bag of bones where you have to put puzzles together. So I opted to do fasciotomy in the front, and at the back I just sort of did a re-look debridement, did as much release of the fascia on the dorsum of the hand, and temporarily put these on while I ordered BioBrain, because that's very good for these abrasions, almost like for your first and second degree burns, so that you get a good skin color afterwards. So then I took her for multiple debridements, planning each time to fix certain things. So then the second debridement, I then opted to fix the volar FDP, FDS. So this fragment that you're looking at here is actually from the radius. So if you actually closed it down, this forms the DRUJ. So she had piano key sign, quite unstable DRUJ, from just this fragment that was holding the DRUJ ligament. And then the lunate cut in half or fractured in half, and then the capitate, some of it missing, scaphoid, part of it missing, but most of it there. So we fixed the lunate and then try to reduce as much as possible. So on the table, I always come up with what I need to do for the patient for that particular day of relook. And this is what I had. And then I do PIN and AIN neurotomies to decrease pain in the wrist afterwards, because I know she's going to end up with some sort of chronic pain in the wrist. So the ultimate fixation, I opted for screws for the 5th base fracture. Lunotroquetrum was unstable, fixed the lunate like before. Then the capitate, the ulnar part of it was actually missing. The hemate was fine. It was able to actually be reduced along with the 4th and the 5th. So I knew that the buried wire, I decided to bury this one and this one, so that I can remove them at 6 weeks and do manipulation, because I knew that she's going to be quite stiff.
I ask, these bones are intercalated, so keeping together by ligament. So you fix the ligament, or just the K-wires is enough?
No K-wires. So the ones that were quite unstable, so this fragment that had the DRUJ on it, so fixed it with this, and then with the suture, part of the TFCC, fixed it. But the lunotroquetrum, these were actually still attached, the intrinsics, they're still attached. The ones that were unstable was actually the STT, so that scaphoid, the whole carpus had been translated laterally. before reduction. So even the radiocarpal ligaments were quite laxed. So then fixed the extensor tendons as well. And then afterwards, I just had to check what was actually repaired and what was working and what wasn't working. So the radial border tendons were actually intact. The first and the second and the third compartments were intact. Then I brought her 6 weeks later. The back was healing quite nicely after BioBrain. And then she had some abrasions that were still healing around the scar tissue. Healed fasciotomy. And just intraoperatively, just to do a bit of manipulation MCP, because she wasn't really active with her occupational therapy from her province. So I was able to show them that, you know, she is able to actually go as far as this for the index and the middle, but she was struggling for small and ring finger. So I did what they call a Sims cast, where you force them into flexion of the MCP, so that they can actually go like this, because I fixed the flexors and extensors of ring and ring and small finger. So she was having problems with, you know, making a fist. So she actually cheated like this. So what you do is you put the MCPs down so that she engages the DIP and the PIPs. So this was her at 6 weeks, and I'm going to see her probably in 2 weeks' time. I think that's all we have time for, unless if you want to do one more case. But I think, okay. And it's not quick, unless if I just go through it, then it will be quick. I think some of you might have actually seen it. Sometimes you get a case where you feel like this guy from the mummy, and you pray to all the gods while you're getting such a case. That happens to be a friend of a family member. So this gentleman was involved in a motor vehicle accident from another province and injured his right hand. So the key here is to remember that things can look very bad from the initial casualty x-rays until you then take them to theater and sort things out. So this obviously looks terrible, and they thought that maybe it's going to be an amputation. So this was what the initial orthopedic surgeon did. So here we have a free-floating thumb. Trapezium was left in the accident somewhere. And then we've got lateral translation of the carpus. So vascularity here was a big issue, especially for the thumb, because you can see here, even clinically, that this is actually a circumferential open wound for the thumb. So perfusion was a concern, especially for the thumb for me. I took the patient to theater, relook debridement, and then it all started making a bit of sense. Brought the thumb up, even though we didn't have a trapezium, and then did the CMC joint reduction. Then afterwards, soft tissue cover. So you always have to look at what is missing. So in this instance, the patient had very good tenosynovium on the extensor tendons, and they were actually not damaged. So I opted just to do a simple skin graft. But with the skin graft in the hand, we know that when it contracts, it actually causes hyperextension contractures. So I put K-wires in initially, so that it doesn't lose that. So this was at 1 year post-op. I knew that the web space was going to be a problem, creeping with the skin graft. And he was able to make a fist, and the skin graft was getting mature, and he had very good function afterwards, yeah. Okay, any questions? Good.
Okay, thanks, Cynthia. It was a great set of cases. So that's the end of the first day. Thank you very much all for staying and the participation. I hope those of you who are new to the meeting get the idea of the format, that we're just here to learn from each other. So don't be shy, don't be worried about giving your opinion. That's what the meeting's here for. So dinner this evening is at 6:30. So you've got about 15 minutes turnaround. It's at the Hussar Grill, which is at the Marriott Crystal Towers. So if you're coming out of the door here, it's right. If you're coming out of the hotel, it's left. Down past the Virgin Active, turn right, and you'll see the hotel with a pool on the front, and it's just on the left-hand side. So 6:30ish onwards, start wandering over there. Early start tomorrow, it's 8 o'clock. Okay, so be down here ready to go at 8 o'clock. Thanks very much. Have a good evening.